great today. We have a wide variety of topics to discuss today, from heart failure to the heart failure guidelines, cardiac rehab, special EP case studies, EKGs, legislative policies, adult congenital heart disease, and then telehealth medicine, as well as some contract negotiations. These topics were actually requested by the CVT members when we initially put out a survey on what they wanted to hear. And we also have a variety of speakers coming from different specialties as well. So before we start, I'd like to show some speakers' disclosure. These are their disclosures. And then there's the learning objectives for the meeting. And we can always go back to this as this meeting is being recorded. And as far as claiming some educational credits, we do have CME credits for this. Actually, it's more contact hours for nurses, clinical nurse specialists, and advanced practice providers as well. For nurse practitioners, they could claim 5.75 up to 5.75 of ANCC contact hours. And for the physician assistants, we do have a 5.75 category 1 CME credits that you could claim through the AAPA category time. In terms of claiming credit, we'll give you a link after the meeting. So just a little bit of promotion here. We encourage everyone to be a part of the ACC family. And then for those of you who are currently members, we have a discount going on right now. It's not sort of a discount, but you can basically buy one, get one for free. So for those who renew this year, we'll have a code to refer a non-member for a free membership for the 2022 dues. And that would be refer CVT 22 code. And for those of you who are not members yet, you can actually avail of this 40% membership due, 40% off membership dues for 2022. If you become a member now, you will receive complimentary membership for the rest of 2021. So again, this is for new members. The code is 4U21. And then for the current CVT member code to refer a non-member for free membership for 2022, it is refer CVT2. Then as far as the end of the session, we will have a Q&A session for the morning session. I would like to have the speakers log back on for the session so they could answer questions pertaining to their topic. So to start the meeting, I'd like to introduce my co-moderator, Barb Novaes. Barb, would you like to say something about yourself?
Good morning, everyone. My name is Barb Novaes, and I'm a nurse practitioner over at Mayo Clinic, and I work in the inpatient general cardiology group.
We also have our AZ governor for ACC, Dr. Kwan Lee, joining us today. Welcome, Dr. Lee.
Hi, good morning, Cecilia. I just want to say thank you, Cecilia, and the CVT team for putting together what looks like a fantastic agenda. It's very exciting. I especially am excited about the second half with the part about contract negotiations, etc. I think there's just not enough of that for our CVT team members, and that's great that you have started to put together that kind of program. This is our fourth annual Arizona ACC CVT team meeting. We were so looking forward to having it in person this year, but at the last minute, as you all are well aware at this point and tired of hearing about, the COVID pandemic situation has forced us to go back to virtual. Next year we are doing this no matter what. We are going to meet in person again. Yeah, this is my last year as the governor of Arizona ACC, and Dr. Wilbur Sue will be taking over from me next year. But I'll definitely continue to be around as the most recent, I don't know what the official term is, Liana, most recent governor or whatever, but yeah, the CVT group is continuously growing. I want to make a plug for the abstract competition session that we'll be having on December 10th, I think, on a Saturday. We would love for the CVT team to submit lots of posters to make an exciting competition. We have extended the deadline because as with all things during the pandemic, everything's a bit last minute. The initial deadline, I think, was November 22nd. We're going to push it to December 3rd so that you have time to put together your posters. You can submit any abstract that you have submitted before as well on a national level so that you can actually use things that you've done before. You don't have to make an entire new poster, but we are very excited about it and we would love to see your submissions and hear from you. Thank you.
Thank you, Dr. Lee. And last but not least, we'd like to thank our chapter executive, Liana Colleen, for being supportive and very helpful for putting this meeting together. I don't think we could have done it without her. Thank you, Liana. So we are going to start with our first speaker here. She's a friend and a colleague. Her name is Dondi Delgado. Dondi is a physician assistant at the Mayo Clinic. A little about Dondi. Dondi was born and raised in Sioux City, Iowa, and initially pursued her master's in sports medicine. She worked for over 7 years as an athletic trainer in different venues around the country, to include the Olympic Games. Wow. After completing her master's in physician assistant studies in Phoenix, Arizona, she got her first PA position in a busy Phoenix cardiology practice. She spent the next 8 years working in cardiology here at the Valley until accepting a position in cardiology at the Mayo Clinic. After hiring, she moved to the advanced heart failure and heart transplant department and has spent the past 11 plus years working in this area. Welcome, Dondi. Thank you.
Thank you, Cecilia. Appreciate the nice introduction. I'll share my screen. And let's see. And do you see my first slide, the ABCs and Ds of heart failure?
We see it in presenter mode, Dondi.
Okay, let's see. How do I get it out of presenter mode?
So see that dot, dot, dot right where you were?
Yeah.
Click on that and it should say hide presenter mode.
Okay.
Oh.
Now it just went.
Go back.
Let's see. Leanna and I practiced this the other day and it went fine. Let's see.
Can you start slideshow up on top, maybe?
Let's see. Let's see, let me stop share and then see if I can change it on my end. Are you seeing anything other than my presenter mode?
No, we see it right now.
Okay. Let's see if I can. There we go. Is that better? Is that
Perfect. Perfect.
Okay, great. Well, thank you again. Sorry for the technical delay. My name is Dondi Delgado, and I'm a physician assistant at Mayo Clinic, as Cecilia mentioned, and been here 11 years and focusing my opportunity to practice in cardiology and advanced heart failure and heart transplant medicine. Today, we're going to talk about the ABCs and Ds of heart failure, and I have no disclosures to provide today. And we find that we are seeing more and more frequent updates to the guidelines, especially as it pertains to heart failure. There's fantastic research, there's a lot of new medications, and it can be a little hard to keep up with all of the changes. So today I wanted to review the 2021 guidelines from the updated version for the American College of Cardiology that came out in January of this year. And a little history first. Interestingly, the very first ACC guidelines that were published for the treatment and management of acute and chronic heart failure was published in 1995. The guideline updates and the expert consensus pathways that would be updated continued to progress over the course of time to where we are now in 2021. And I think as you can see here with the slides, you're starting to see it become more frequent, a 2017 update, a 2019, 2020, 2021, where before we would have a few years span between updates and guidelines. And I suspect we may even start to see updates and guideline changes more than once a year as more medications and new therapies become available. So in 2001, what was the big change? Well, the big, huge change that affected all of us in research for the next 20 years was the development of the stages of heart failure. So this was published in 2001 and has been in use for the last 20 years. So the stage A, which was high risk for heart failure, but without structural heart disease, so just your at-risk patient, your stage B, which had structural changes, but no symptoms or signs of heart failure, your stage C, which is now structural heart disease with symptoms of heart failure, and stage D, which is your refractory heart failure requiring more specialized interventions. The classifications from the New York Heart Association have also been a cornerstone of how we identify our patients in their clinical syndromes. Again, class 1 without any limitations of activity. Class 2, slight limitations of physical activity, but comfortable at rest. And they may get symptoms with ordinary physical activity through the day. Class 3 would be marked physical limitation of activity, and less than ordinary activity causes their symptoms of heart failure. And class 4, unable to perform any physical activity without symptoms of heart failure or symptoms of heart failure at rest. The other key terms that we're going to be talking about today is GDMT, Guideline Directed Medical Therapy, and this represents the treatment options supported for use by clinical practice guidelines. The heart failure with reduced ejection fraction, the cutoff for the talk of heart failure with reduced ejection fraction is less than or equal to 40% unless otherwise referenced. And the optimal therapy is the treatment provided at either the target or the highest tolerated dose for a given patient. And target doses are the doses targeted in the clinical trials. So in the ACC 2021 update, they came up with 10 items that were really targeted in the update that were broke down into 3 categories: how to implement GDMT, how to address challenges with GDMT and heart failure, and how to manage your patients. So in issue 1, it was initiate, add, or switch. And they developed a treatment algorithm for GDMT, including more novel therapies, the titration of these new medications, and the considerations for monitoring. Item 3, referral and your triggers to referral to a heart failure specialist. 4, care coordination and the essential skills and infrastructure needed for a heart failure team. Adherence and issues related to non-adherence for your patients. Item 6, specific patient cohorts. Item 7, medication costs and access. Item 8, increasing complexity of your heart failure patient. Item 9, comorbidities. And of course, 10, palliative care and hospice considerations. The clinical stages of heart failure are something that we're all very familiar with, but again, as it comes to reviewing guidelines and information and application of these GDMT therapies, it is important to know where you are with your patient, because it will help guide your decision on the appropriate initiation and titration of the medications that are recommended in the guidelines. So your optimal patient is dry and warm, and that's a well-compensated heart failure patient. To your wet and warm patient with adequate perfusion, but now congested. Your wet and cold patient who is with a congestion as well as a low perfusion. And your dry and cold patient that is not congested, but lacking the adequate cardiac output and index needed to maintain perfusion. So the first thing to review is initiate, add, and switch. So how to initiate therapy in a newly diagnosed heart failure with reduced ejection fraction. ARNI is preferred with a beta blocker, and then your diuretics is needed. Which do you start first? Is it the chicken? Is it the egg? The ARNI, if the patient is wet, should be considered first. If the patient is dry and warm with an adequate resting heart rate, you could consider your beta blocker first. Hold off on your beta blocker if your patient is cold. Oops, sorry, I think, hold on, my screen went to a different mode on my reader screen. The chronic heart failure patient with reduced ejection fraction, again, is the ARNI. This was shown in your paradigm HF, which demonstrated an absolute reduction in primary outcomes of cardiovascular death and heart failure hospitalizations in patients treated with your ARNIs over your ACE inhibitors. The number of patients needed to treat to prevent one endpoint was 21 patients to prevent one primary endpoint over 27 months. And these differences did include outcomes that included a 20% reduction in sudden cardiac death. Now, what about HFpEF? HFpEF is the definition of a patient with an ejection fraction of 50% or greater. And Paragon HF showed a borderline effect of ARNIs in the primary composite outcomes. However, there was a 15% reduction in heart failure hospitalizations. This reduction seemed to be most evident in patients with an LVF of below normal, so below that 50%. And that really introduced the heart failure with mid-range ejection fraction, or HFmrEF, or as I like to say, HFmEF. So an EF of 40 to 49%. So the ejection fraction of 40 to 49% in combination with signs and symptoms of heart failure, this group really seemed to benefit the most from the ARNI in Paragon HF. Next item that comes up often is titration. How do we titrate? When do we titrate? And what are our goals to get there? And the titration goals are to achieve the optimal doses used in clinical trials. That will give you your best outcome. And obviously we tailor those to patient toleration. The goal, the goal is to get to optimal titration doses in 3 to 6 months of your guideline-directed medical therapy. So over the course of 3 to 6 months, you're initiating ARNIs, beta blockers, MRAs, and other novel therapies as appropriate to your patients within 3 to 6 months. Also worth mentioning is ivabradine. Now, this was updated in the 2016-2017 guideline updates by the ACC, but also got mentioned again in the 2021 updates. Ivabradine is an adjunctive means to reduce heart rate in patients with chronic HFrEF who are in sinus rhythm. The heart rate of patients independently predicts outcomes with HFrEF. And the initiation of ivabradine reduced the risk of heart failure hospitalizations in patients with HFrEF with an ejection fraction of less than 35% already receiving GDMT therapy, including your beta blockers at maximally tolerated dose, and who maintain sinus rhythm with a heart rate of greater than 70 beats per minute. Now, the new sexy kid on the block is the SGLT2 inhibitors, which I know Janice is going to dive into a lot deeper, so I will go over lightly. The SGLT2 inhibitors have been approved with multiple trials, DAPA-HF, DEFINE-HF, Emperor-Reduced, to name a few. And the analysis showed that the effects of EMPA and DAPA on hospitalizations for heart failure were consistent, and the agents reduced all-cause and cardiovascular death and improved renal outcomes in patients. And the SGLT2 inhibitors are to be used in addition to your other guideline-directed medical therapy. It can be started at any time. Earlier is better, as we will see. One quick pause. My reader notes are not coming up for my screen. 1 second, please. So most recently in the ACC news, the canagliflozin was shown to reduce heart failure symptoms within 3 months, regardless of ejection fraction or diabetic status. And this was shown in the CHIEF-HF trial. This trial included 476 patients with HFpEF and HFrEF with and without diabetes, and there were no new safety issues revealed. IMPO in the IMPULSE trial showed that starting empagliflozin in patients with acute heart failure were 36% more likely to show clinical benefits at 90 days than placebo. So again, SGLT2s are important, and they are able to be started even in acute heart failure settings. So the next item is, when do you refer? And the clinical triggers for referral include persistent or worsening symptoms, adverse clinical events, or features of worsening disease progression or death, such as GDMT de-escalation, which is a bad prognosticated value. The I need help includes IV inotropes, NYHA class 3B or 4 with persistently elevated BNP, end organ dysfunction, an EF of less than 35%, ICD shocks, hospitalizations of greater than 1 for heart failure, edema despite escalating diuretics, a low systolic blood pressure of less than 90 with a high heart rate, and again, P for prognostic medication, which is that progressive intolerance or down titration of guideline-directed medical therapy. Other indications for referral include second opinion that's needed regarding the etiology of heart failure, valvular disease to include the value of possible valve repair, suspected myocarditis, established or suspected specific cardiomyopathies such as hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, Chagas, restrictive cardiomyopathy, sarcoidosis, and amyloidosis. An annual review is needed for patients with established advanced heart failure, in which patients and caregivers, as well as the clinicians, discuss the current and potential therapies for both anticipated and unanticipated events, possible heart failure disease trajectory, prognosis, patient preferences, and advanced care planning, as well as assessment of patient for possible participation in a clinical trial. So when you see I need help, or when you find yourself in the I need help algorithm, it is referral time. Oh, sorry, it's in advance. The referral to a center that can provide advanced heart failure therapies such as left ventricular assist device and heart transplant, or the referral to a palliative care or hospice team. Additional reasons to refer, again, care coordination, a team approach to management of medication costs and access, increasing complexities, is assessing for non-adherence, addressing for specific patient cohorts that may benefit from the closer management or addition of alternate medications for therapies, and consideration of new therapies that might be developing at each individual center. Severe mitral valve regurgitation and use of transcatheter mitral valve repair. The MITRA-HF study demonstrated no benefit. The MITRA-FR study demonstrated no actual benefit, but the COAPT study showed benefit. The difference there is that in the COAPT study, the patient was on maximally tolerated GDMT and device therapy. And in that population, there was a reduction in heart failure hospitalization and mortality in symptomatic heart failure patients with grade 3 to 4+ MR. Surgical treatment is recommended in the cases of severe primary chronic mitral valve regurgitation resulting in HFrEF. But for your patients who have HFrEF with functional mitral valve regurgitation 3 to 4+, MitraClip could be considered for therapies. CardioMEMS. In the CHAMPION study, they demonstrated that patients with NYHA class 3 heart failure symptoms that were assigned to receive implantable PA pressure monitors had better outcomes, in that they had a 28% relative reduction in heart failure hospitalizations. This improvement was actually seen in patients with both HFrEF and HFpEF. The impact on mortality continues to be evaluated in GUIDE-HF, but a team-based approach is likely best to continue to monitor these patients closely. The indication are class 3 symptoms with 1 hospitalization in the past year. But this is an option for all of our class 3 heart failure patients. Filling pressure assessments. The filling pressure assessments or the right heart catheterizations are invasive hemodynamic assessments, but they are helpful in patients with refractory symptoms despite their adequate dosing of diuretics. Other opportunities to do interventions with the right heart catheterization include repeated hospitalizations for heart failure and a decision on therapies for the patient and possible need for referral for advanced therapies. The guiding principles that come into play for heart failure and your advanced heart failure patients are: number 1, GDMT is the foundation of heart failure care, and the GDMT with highest expected benefit should be prioritized. Principle 2, target doses are associated with best outcomes. Principle 3, start GDMT immediately. Principle 4, attention to the clinical, social, and financial barriers of achieving GDMT should be prioritized. Principle 5, diligent management of volume status will reduce patient symptoms. Principle 6, tolerability and side effects depend on how and when GDMT is prescribed. Principle 7, ICD and CRT therapy should be considered after consistent use of optimal doses of all GDMTs for at least 3 to 6 months, followed by a reassessment of EF. Principle 8, transcatheter mitral valve repair can be considered among symptomatic patients with chronic moderate to severe mitral valve regurgitation with optimal doses of all GDMT therapies. Number 9, focusing on the patient's symptoms, functional capacity, and cardiac function. Number 10, the value of therapy to a patient is in fact the combination of benefits and burdens as they relate to the patient's values, goals, and preferences. And principle 11, team-based care is critical to optimizing GDMT. So what are the ABCs and Ds of heart failure? Know where you are with your patient, your stage, your class. Are they HFrEF, HFpEF, or HFmrEF? Letter B, GDMT, initiate, add, switch, titrate over 3 to 6 months to get to goal. Additional therapies and interventions such as MitraClip, CRTs, and CardioMEMS. And D, I need help. Refer to a center for mechanical circulatory support or transplant, or consider referral to palliative care hospice if they are not a candidate for those therapies. Future updates that could be coming our way include Vericiguat. This has been FDA approved in January of this year. Initiate after heart failure hospitalization or an outpatient need for IV diuretics. This was reviewed in the Victoria study. Also, cardiac myosin activator or myotropes are not FDA approved currently, but they directly augment sarcomere function. And the positive cardiac inotrope has been shown to improve cardiac functions with reduced ejection fraction. Cardiac contractility modulation is a device-based therapy. The Optimizer Smart System was approved in by the FDA in March of 2019. Baroreceptor activation results in centrally mediated reduction of the sympathetic outflow and increased parasympathetic activity. This was improved in August of 2019. Other updates that could be coming are terminology changes. You'll see heart failure with improved ejection fraction. There has been suggestion by the European Society of Cardiology to change heart failure with mid-range ejection fraction to mildly reduced, and perhaps more specific definitions for advanced heart failure. The European Society of Cardiology released their guideline updates just in September of 2021, and they had further recommendations on referrals to end-of-life care, as well as new concepts that may be coming, such as the mildly reduced terminology, new algorithms and classifications, phenotyping, and genetic testing. Thank you so much for your kind attention today. It's been my honor and pleasure to be able to present to you more information on advanced heart failure.
Thank you so much, Dondi. That was a great presentation. And you stayed composed despite all of your technical issues.
My one screen would advance and the other one wouldn't, so I'm sorry I got behind.
No, you did a great job. Thank you. Just a reminder that we're going to have a Q&A session at 12 o'clock today. So you can submit any of your questions through the Q&A button down at the bottom of your screen. Our next speaker is Dr. Janice Stephen. She also is going to be speaking to us on heart failure guidelines. She grew up in San Diego, California, and pharmacy brought her all around the country. She went to pharmacy school at Midwestern University, Chicago College of Pharmacy, and then she traveled to Philadelphia, Pennsylvania for her postgraduate year 1 training in internal medicine. She then found herself in Minneapolis, Minnesota to do further training in solid organ transplantation. After that, she moved to Phoenix, Arizona, where she is now at Mayo Clinic, working as the heart transplant clinical pharmacy specialist. Welcome, Janice.
Thank you. Let me get us started. All right. So first off, I want to thank you guys for giving me the opportunity to speak to you all today. My name is Janice Stephen, and I am the clinical pharmacy specialist in heart failure and transplant here at Mayo Clinic. Today, I will be speaking with you about the most recent addition to the heart failure guidelines, and you can kind of consider this a second part to Dondi's lecture that she just gave. As far as disclosures go, I have no disclosures, but I will be speaking off-label of some medications. Today's objectives are to examine the mechanisms of action of dosing recommendations and side effect profiles associated with sodium glucose cotransporter 2 inhibitors, otherwise known as SGLT2 inhibitors, to evaluate the evidence supporting the use of SGLT2 inhibitors in heart failure with reduced ejection fraction, or HFrEF, and to determine the optimal patient for which an SGLT2 inhibitor should be initiated. Let's start with the mechanism of action. SGLT2 inhibitors were first developed as a new class of oral anti-hyperglycemic agents for the treatment of type 2 diabetes mellitus. SGLT2 inhibitors work in the proximal tubules of the kidneys. They reduce glucose reabsorption, leading to glucosuria. This, in effect, reduces the amount of circulating glucose in the body. So patients essentially pee out the glucose that they have in their bodies. The 3 SGLT2 inhibitors that are currently on the market are dapagliflozin, or also known as Farxiga, empagliflozin, also known as Jardiance, and canagliflozin, also known as Invokana. The doses of each of these 3 agents differ as well. Dapagliflozin can be started at 5 milligrams or 10 milligrams, but 10 milligrams daily is the maximum target dose. Empagliflozin can be started at 10 milligrams and can be increased to 25 milligrams once a day if needed for glycemic goals. Canagliflozin can be started at 100 milligrams and increased to 300 milligrams once daily if needed for glycemic goals. So let's move on to the side effect profiles of our SGLT2 inhibitors. The most common adverse effect of SGLT2 inhibitors are genital infections, including urinary tract infections and genital mycotic infections, which makes sense, right? If patients are peeing out glucose, it makes sense to have bacterial infections or urinary tract infections in that area. It's also important to realize that SGLT2 inhibitors do induce some form of diuresis, which can lead to volume depletion as well. There are several landmark trials that introduced SGLT2 inhibitors into the cardiovascular world. These were CANVAS and CANVAS-R, DAPA-HF, Emperor Reduced, and DAPA-CKD. This isn't all-inclusive, but these were the ones that I found the most important with the guidelines. The first trial were CANVAS and CANVAS-R. This looked at canagliflozin and cardiovascular and renal events in type 2 diabetic patients who were at high risk for cardiovascular events and the effects on reducing cardiovascular mortality, non-fatal myocardial infarctions, or non-fatal strokes. The trial was a multi-center, double-blind, placebo-controlled trial. The primary outcome was the composite of death from cardiovascular cause, non-fatal myocardial infarctions, or non-fatal strokes. The trials concluded that patients with type 2 diabetes and elevated risk of cardiovascular disease treated with canagliflozin had a lower risk of cardiovascular events than those who had received placebo. However, it was also found that the canagliflozin group was at a greater risk of amputation, primarily at the level of the toe or metatarsal. For those who are more visual, I have the graph here. The trial showed that 31.5% of patients in the placebo group had an event compared to 26.9% in the canagliflozin group. This was statistically significant. Then we had the DAPA-HF trial. DAPA-HF was dapagliflozin in patients with heart failure and reduced ejection fraction, and was the first trial of an SGLT2 inhibitor to specifically look at the treatment of patients with HFrEF with or without diabetes. It was a multi-center phase 3 placebo-controlled trial. The primary outcome for this trial was a composite of worsening heart failure, which was defined as a hospitalization or an urgent visit resulting in IV therapy for heart failure, or cardiovascular death. The trial was significant because it showed that among patients with HFrEF with or without type 2 diabetes, the addition of dapagliflozin reduced rates of cardiovascular death or worsening heart failure, as well as all-cause mortality. It showed that only 16.3% of patients in the dapagliflozin group had an event compared to 21.2% of patients in the placebo group. This was statistically significant. This trial was really what got dapagliflozin the FDA label use of heart failure with or without type 2 diabetes. And to be fair, when I first came up with the title of this talk, dapagliflozin was the only one that had that label. So that's where the title came from. The empagliflozin outcome trial in patients with chronic heart failure and reduced ejection fraction, or EMPEROR reduced trial, evaluated use of empagliflozin in patients with HFrEF with or without type 2 diabetes. And if it reduced cardiovascular mortality and the progression of heart failure compared to placebo. This was a multi-center double-blind placebo-controlled trial as well. The primary outcome was the composite of cardiovascular death or hospitalization for worsening heart failure. The EMPEROR reduced trial showed that among patients with or without type 2 diabetes on guideline-directed medical therapy, or GDMT as we call it, for heart failure, those that were also on empagliflozin had a lower risk of cardiovascular death or hospitalization. Sorry, I forgot to advance the slide. Here we go. Had a hospitalization or heart failure than those with the placebo. So 19.4% of the patients in the empagliflozin group experienced an event compared to 24.7%, which was statistically significant, as well as clinically significant, such that empagliflozin does now have the FDA label use of use in patients with HFrEF with or without diabetes. DAPA-CKD looked at dapagliflozin in patients with chronic kidney disease with or without type 2 diabetes. This was also a multi-center double-blind placebo-controlled trial, and the primary outcome of the trial was the composite of a sustained decline in estimated glomerular filtration rate of at least 50%, end-stage kidney disease, or death from renal or cardiovascular cause. The trial showed 9.2% of patients experienced an event compared to 14.5% in the placebo group, which was statistically significant. This means that our patients with CKD with or without diabetes at cardiovascular risk of death, decline in GFR, end-stage renal disease, or death from a renal cause, the risk was significantly lower with dapagliflozin when compared to placebo. One of my first slides was actually the mechanism of actions of SGLT2 inhibitors and how that helps diabetes. But now we see that it also helps patients with HFrEF. But how it helps heart failure is not entirely clear. Some proposed explanations include diuresis, natriuresis, and osmotic diuresis. They also seem to affect hemodynamics by reducing interstitial volume, causing blood pressure reduction, improve vascular resistance. It's also thought that SGLT2s may improve cardiac metabolism and bioenergetics, which tend to be inefficient in patients with heart failure. There are currently ongoing trials investigating the how or the mechanism of which dapagliflozin and empagliflozin work on heart failure. As of now, there's no definitive rationale that is understood, but I think there will be in years to come. I do want to mention that there are also clinical trials looking at empagliflozin in HFrEF with renal dysfunction. So I suspect that will soon get approved as well. And there's also studies looking at SGLT2 inhibitors with heart failure and preserved ejection fraction. It's an exciting time for SGLT2 inhibitors, so stay tuned. Lastly, I want to give a patient scenario that kind of brings everything together that you've heard in the last hour. So we have JC, who is a 55-year-old Caucasian male who presents to clinic with significant past medical history of ischemic cardiomyopathy and heart failure with an ejection fraction of 23%. He says that lately he's felt more short of breath. His current medication regimen includes lisinopril, PO daily, Lasix 20 milligrams daily, and Coreg 3.125 PO BID. What changes to medication would you like to make? So the way I kind of think about this is that given the increase in shortness of breath, the patient likely needs to be on more medication. From a GDMT standpoint, we heard from our previous speaker that it's important to add on various GDMT before titrating up. So given that information, these are the changes I would like to recommend. I would consider holding the lisinopril for 36 hours to initiate Entresto 24-26. If his heart rate can tolerate it, I would increase his carvedilol. And I would also initiate an SGLT2 inhibitor. If his labs are acceptable, I would consider a mineralocorticoid receptor antagonist. And his diuretics will likely need to be adjusted as well, but I would make these changes after the other medication changes are done, because we know both the ARNI as well as the SGLT2 inhibitors can have some diuresis naturally with that. If all of the above actions have taken place and the patient is still symptomatic, I would send the patient for evaluation at a center that does advanced therapies for heart failure. Clinical pearls for SGLT2 inhibitors are that SGLT2 inhibitors are recommended for patients with HFrEF regardless of their diabetic status. There is an increased risk of recurrent UTIs or urinary tract infections. So if your patient has a history of recurrent UTIs, SGLT2 inhibitors may not be the ideal medication for this patient. Canagliflozin had a twofold increase of lower limb amputation compared to placebo. I do want to mention that dapagliflozin trials did not show that same increase of amputation. However, given the FDA warnings on canagliflozin, it might be reasonable to apply to the use of other SGLT2 inhibitors. And then, of course, for completeness sake, I do want to mention that only that dapagliflozin or Farxiga and empagliflozin or Jardiance are the only two SGLT2 inhibitors with an on-label indication for use in heart failure with or without diabetes. The dosing of each of these medications is 10 milligrams. So if you have a patient that has HFrEF without diabetes, then you would do 10 milligrams. If you have a patient with HFrEF with diabetes, for the dapagliflozin, you could still use 10 milligrams. And you can use 10 milligrams from empagliflozin, but if you're not getting your hyperglycemic goals, then you would consider increasing it to 25 milligrams, which is the diabetic dosing of empagliflozin. Finally, SGLT2 inhibitors are now considered part of the guideline-directed medical therapy for patients with HFrEF with or without diabetes. So it should be considered in all patients with heart failure with reduced ejection fraction. And we're saving questions till the end, but that's all I have for you guys today. So thank you very much for letting me speak to you.
Thank you, Dr. Stephen. Fantastic talk. So we're moving on to a different topic of cardiac rehabilitation. For this topic, we have two speakers, Holly Bright and Christine Kane. A little bit about the speakers. Christine has been a registered nurse for 37 years and has worked in cardiac rehab at Mayo since 2006. Most of her career has been spent in cardiology. She recently received CCRP as a certified cardiac rehab professional. And she is into wellness, magnet and cardiology, UBT, and EPIC committee at the Mayo Clinic. Holly Bright is a senior exercise physiologist at Mayo Clinic, Arizona, and is also a fellow of the American Association of Cardiac and Pulmonary Rehabilitation. She started her career in teaching after receiving her Bachelor's of Science from Oklahoma State University, then pursued her interest in exercise physiology, obtaining a master's degree from the University of Northern Iowa. She has been with cardiac rehabilitation in Arizona for over 35 years and has been active in the Arizona Society for Cardiovascular and Pulmonary Rehabilitation, serving on the board as a president, secretary, and member at large. Holly has also been involved nationally with AACV-PR as a health and public policy committee member. She has presented in current practice and research in cardiac rehab at both state and national level. Welcome, Holly and Christine.
Thank you. Excuse me. Thank you very much for having us. Holly and I are both considered senior staff, which means that we're just very old. We have no financial disclosures. So we're going to start doing our talk with kind of the evolution of physical activity with the coronary patient. In the 1930s, the standard practice for patients with any coronary event was to remain on bed rest for at least 6 weeks. In the 1940s, they could sit up in the chair very briefly, usually for meals. In the 1950s, we got really crazy. Patients were able to do 3 5-minute walks every day, but this did not occur until 4 weeks after their event. In 1968, there was a study done. It was the Dallas Bed Rest and Exercise Study. And this showed how harmful prolonged bed rest could be for the patient and how important exercise was. This study used 5 healthy male students. Fast forward 30 years, and these same 5 men returned and completed an exercise endurance program. The surprising result showed that 3 weeks of bed rest on these healthy men had a more profound effect on their aerobic fitness than did the prior 3 decades of aging. We gradually recognized the importance of early ambulation, prevented additional complications with no added risk. So inpatient cardiac rehab was formalized in the 1960s. Patients were able to do supervised reconditioning at very low levels while still in CCU or ICU, and it showed promising results. By the end of the 1960s, Dr. Hellestein started the first outpatient cardiac rehab, and his comprehensive approach has now been adopted in most of the developed countries. Current models of cardiac rehab include medically supervised exercise programs, lifestyle modifications, progression of activity while the patient is being monitored, overall progression from inpatient to the outpatient side and through the maintenance program, and this builds confidence. They are allowed 36 sessions per protocol, and now there is being developed virtual and hybrid models using the newest technology and even phone apps. However, a physician referral is still required for a patient to participate. Early cardiac rehab is an ongoing, comprehensive educational and exercise program designed to improve the patient's cardiovascular health and recovery from heart conditions. We work in conjunction with physical, occupational, and rec therapies, dietitians, and the medical team to provide the best outcome for our patients. The cardiac rehab mission is to restore and maintain an individual's optimal physiological, psychological, social, and vocational status. The overall goals of cardiac rehab, of all phases of cardiac rehab, are to identify, modify, and manage their risk factors, which reduces disability, morbidity, and mortality. We want to improve their functional capacity, alleviate any activity-related symptoms, and we want to educate the patients and their families about the management of heart disease, which improves their overall quality of life. There are 3 phases of cardiac rehab. Phase 1 is when we meet the patient in the hospital. We provide education and activity, and this is our main focus. Phase 2, the patient now begins the monitored exercise session as an outpatient. This is a class 1 recommendation. Phase 2 consists of 36 sessions, and it is covered by most insurances. It is a specific exercise program that is designed for the patient by the exercise physiologist. Phase 3 is a maintenance exercise program. The patients are doing the exact same exercises, but they no longer are wearing the monitor, but is being supervised by the staff. This is for people who have probably graduated from the phase 2 program, or their diagnosis is not covered by insurance. However, we continue to build confidence with this patient, and adherence for heart healthy lifestyles are increased. The phase 1, or the inpatient cardiac rehab program or session, begins in the hospital. We must have an order from the provider to be able to see a patient. At Mayo, we are part of an order set for the CT surgery, cath lab interventions, and heart failure teams. It is during the hospital stay where we begin the education specific for that patient's diagnosis. We put together and distribute informational packets for the following diagnoses: heart disease, stents, MIs, SCAD, Takotsubo, heart failure, LVADs, TAVRs, mitral clips, and heart surgeries, which include bypass, valves, and heart transplants. Our emphasis during this time is on education and review with the patient and their families. Some of these patients have been living with their diagnosis for quite a long time, and this simply is just a review. But others, this is a new diagnosis. It can be very frightening and overwhelming for both the patient and their family. We are there to educate, but we also build a rapport with the patient and reassure them and their families using a calm manner and constant review of information. The patient becomes more confident, and both the patient and their families are better prepared for discharge. Along with education, we discuss the risk factors: smoking cessation, heart healthy diets, sodium and fluid guidelines, stress management, sternal precautions, post-cath site care, and heart transplant education. We stress the importance of ambulation progression, medication compliance, and we reinforce the care team's instructions. As the patient prepares for discharge, we discuss, I'm going to go back, I went a little early. As the patient prepares for discharge, we discuss the phase 2 program. We are able to provide contact information for local, state, and national programs, and we try to do this to make it the most convenient program for the patient. Our goal is that we want them to participate in a program. So why order cardiac rehab? Well, there is a partnership that develops about the patient's care. It's between the patient, the cardiac rehab staff, and the provider. It is a Class 1 recommendation, and it's another set of eyes on the patient for continuity of care, safety, and improved outcomes. Patient satisfaction is improved. Patients become more involved in their care, and they have improved medication compliance, safe exercise behavior, which all lead to long-term health benefits. Ideally, the referral should take place while the patient is still in the hospital or right at discharge, but it can also be, a referral can also be placed at any follow-up visit. It must be ordered, signed by a physician, but it can be proposed by a nurse practitioner, RN, PA, and like I said, co-signed by the physician. Now, Holly will speak on the other phases of cardiac rehab and some additional information. Thank you.
Okay, I have to get the speaker's view here. I'm hoping I can do that. Let's see. Okay. Well. Well. Okay. All right, well, I am going to wing it. Okay, so thank you for the opportunity of talking to you today about cardiac rehab. We always like the opportunity to tell you how important cardiac rehab is in the recovery of the patient. So we're going to get into the nuts and bolts of the eligible diagnoses. Medicare seems to guide us in what is eligible. Probably the one that is the caveat is the heart failure diagnosis, and we'll talk about that in a little bit. But the myocardial infarction, that's the only one that's within a year. That's the only one with a time frame associated with it. If you have a patient that's had a CABG or a PCI in the last couple of years that hasn't had participation in cardiac rehab, you can get them into the program. Private insurances take Medicare's lead, and they cover the same diagnoses that Medicare does, but they also may provide coverage for patients with HFpEF and cardiomyopathy, septal myectomy, and atrial fib, things like that. The ones that fall through the cracks are the ones like Dondi coined, the HFmEF. Those are the ones with an ejection fraction of between 35 and 45. They're the ones that get not able to be in cardiac rehab phase 2, but can be sent to phase 3. So the heart failure specifics, it was taken from the heart failure action trial criteria for subjects. So that's why they're limited in this way. So in order for them to come through our doors, they have to have an EF of 35% or less. And they have to have been on optimal heart failure therapy for at least 6 weeks. So new meds, diuresis, and what have you. Stable patients are defined as those who have not had a recent or planned major cardiovascular hospitalization. So cardiac rehab is a low cost, low tech, it's very powerful medicine. It's a class 1 indication for most of the diagnoses. And this is an old slide over here. It's saying that less than 20% of patients eligible for cardiac rehab are actually referred. That has improved, and through the efforts of our national society and each program, we have bumped up that referral rate to 59% from the providers. However, getting them through our door is another matter. That still is only about 10 to 30% of patients that are referred that get cardiac rehab. One of the things that we know is a problem is sometimes we hear from the patients, oh, my doctor said I can do this on my own. And but we're much more than just an exercise program. We give them support through their most vulnerable time of their recovery. So there's strong benefits that have been shown by many, many studies. So reduced all-cause mortality, 12 to 24%. Readmission rates are lowered. Cardiac mortality can go down within the next 5 years. The more sessions they complete, the lower their risk is of having another problem in the next 5 years. Improved adherence with some of the medications, improved function and exercise capacity. It really helps with their mood, their ability to do things and have a better quality of life, get back to their ADLs. We reinforce what the providers have set out for them as far as modifiable risk factors. And we just, like Christy said, we're more eyes on the patient, and we help them as they recover. So here's some references that support all the clinical and health benefits. I also wanted to let you know that we have a national society and a state society. These societies, the National Society offers us an ability to stick with the guidelines and show that we can adhere to the excellence core competencies that are set out for cardiac and pulmonary rehab. And we also have a certified cardiac rehabilitation professional certification just recently, and Christy just got that like within 2 weeks. So it just ensures that we are meeting the professional guidelines. We also have an advocacy arm for different legislative issues. We have to change language in order to get better coverage. And we have educational meetings where we get to learn about new treatment options and also network. We have a very active state society. We have a good website. If you ever wonder if you have a patient that needs cardiac rehab and you wonder if there's a program close to them, you can go to this website and see what programs are located in what part of the valley or state. Our state society puts on an annual conference and quarterly meetings to keep us up to date on current practices. We have a partnership with ASU and their exercise physiology master's program. And again, more networking. So we try to stay up to date with all the latest information. The heart failure drugs, that was an interesting presentation for both of the previous speakers. We see a lot of patients on the Entresto type of drugs, and we're here to monitor those blood pressures and to reiterate, more eyes on the patient. And we have a good time with the patients. We get to know them over 36 sessions. We help them emotionally and just support them in many ways. And to talk about the advocacy arm, we have a current bill that's in Congress to improve access to care. And this involves the NPs and the APPs. And we're trying to get them to be able to supervise cardiac rehab. The effective date from a previous bill is 2024, but we're trying to have that moved up to 2022. So we haven't gotten the piece where the non-physician practitioners can order cardiac rehab, but we are working on that because that would help us tremendously. We so appreciate the non-physician practitioners ordering cardiac rehab. Whether there's a physician co-signature on that, we will get that. But the fact that you think of us and you order us means the world to us and to your patients. So we're all in it together for the patients. So cardiac rehab, it's just a mouse click away. So thank you again for the opportunity, and just order us and we'll help the patients. Thanks.
Thank you so much, Holly and Christy. That was a great talk, and thanks for reminding us of the benefits of cardiac rehab and how important it is for our patients. Our next speaker is Ron Ordaz. Ron, a little bit about Ron. He completed both his bachelor's and master's degree in nursing at Emory University in Atlanta, Georgia. And after graduation, he moved to Arizona, and we were fortunate enough to have him as a nurse practitioner fellowship in our cardiology department in 2013. Seems like it wasn't that long ago. And since that time, he's been working as a nurse practitioner at Cardiovascular Institute of Scottsdale alongside Dr. Haddad, who's an interventional cardiologist. He enjoys all areas of cardiology, but has a special interest in coronary artery disease and vascular disease. Ron is going to speak to us on cardiac amyloidosis, when a zebra is just a horse. Welcome, Ron.
Thank you. Can you see my screen okay?
I see your face.
You just see my face. Okay. Let's see.
Can you screen share on the bottom?
How about now? Better?
Yeah, you're in, there you go.
Perfect. Okay, thank you. I want to thank you, Barb, and you, Cecilia, for inviting me to speak today and allowing me to choose this topic. I have no relevant disclosures. And so my objectives today are to define amyloidosis and recognize cardiac symptoms that may raise suspicion for amyloidosis, describe and provide a framework for differentiating between AL and ATTR. These are the two most common forms of amyloidosis with cardiac manifestations. Understand the role and limitations of testing and diagnostic imaging in AL and ATTR, and describe a potential treatment option for ATTR. And I'm also going to utilize a case study to illustrate a cardiac amyloidosis workup. So just some definitions. Amyloid is just a non-specific term for a precursor protein with the potential to cause disease. Amyloidosis is a disease state marked by a pathologic misfolding of an amyloid precursor protein with subsequent deposition into tissues, resulting in a variety of pathological conditions. The two most common forms of amyloidosis with cardiac implications include AL and ATTR. So AL stands for amyloid light chain. It's a plasma cell bone marrow disorder characterized by misfolding of antibody light chain fragments, resulting in pathologic deposition into cardiac or non-cardiac tissue. Critical to any cardiac amyloidosis workup includes ruling out AL, as AL requires a swift referral to hematology or oncology for further workup. ATTR stands for amyloid transthyretin, and it's a disorder characterized by destabilization of a transthyretin protein tetramer into a monomeric misfolded amyloid fibril with pathological deposition into cardiac and non-cardiac tissue. Transthyretin role physiologically is to transport T4 and retinol. So patients that may raise suspicion in your clinic for cardiac amyloidosis include your heart failure with preserved EF patient. They may complain of fatigue, dyspnea on exertion, abdominal distension, or lower extremity edema. And maybe 13% of your heart failure with preserved ejection fraction patients may have some form of cardiac amyloid. You may have unexplained LVH on an echocardiogram with a normal or low QRS voltage on EKG. The QRS is low as the ventricular wall thickening is not necessarily due to an increase in LV mass, but is due to deposition of amyloid fibrils within the cardiac tissue. Hypertrophic cardiomyopathy, perhaps 5% of your HOCM patients may actually be amyloid patients. Patients with aortic stenosis, you may see low flow, low gradient AS, but there's also some consideration for TAVR patients. They say maybe as many as 16% of your patients that are undergoing TAVR may have cardiac amyloidosis. Patients with AV conduction disease due to amyloid infiltration of the conduction system. Atrial arrhythmias due to atrial remodeling. Patients with persistently elevated troponins, every time they come in the hospital, they have that troponin of 0.08, and that's just due to secondary small vessel ischemia. And then a patient that was previously hypertensive, but suddenly is hypotensive, or they're coming and complaining of postural hypertension, and that's due to autonomic dysfunction. And it may, these patients may be intolerant to guideline-directed medical therapy, including beta blockers, ACEs, and ARBs. Some non-cardiac signs, sensory motor or autonomic neuropathy, bilateral carpal tunnel syndrome, paresthesia, numbness, autonomic dysfunction, musculoskeletal issues such as lumbar stenosis, unprovoked bicep tendon rupture, renal manifestations, proteinuria, nephrotic syndrome, GI, diarrhea, constipation, nausea, vomiting. So here's just a schematic kind of comparing AL and ATTR. So on the left is AL, it's overproduction and or misfolding of antibody light chain fragments into amyloid fibrils, and then deposition into cardiac tissue or other tissues. And on the right is ATTR, which is degradation of the transthyretin tetramer into monomeric fragments and subsequent misfolding into amyloid fibrils, and that's ATTR. So kind of first things first, you want to rule out AL. And so you could do serum and urine immunofixation. They're no longer recommending SPEP and UPEP. You do serum-free kappa and serum-free lambda light chains and get a ratio. And if you see an abnormality, you refer for a hematological workup. AL amyloidosis, it's rapidly progressing and life-threatening, and treatment includes chemotherapy to inhibit production of abnormal plasma light chains, and perhaps a stem cell transplant or even heart transplant. Back to ATTR amyloidosis, again, that TTR, it transports thyroxine and retinol in its tetrameric form. And ATTR, it's either a genetic hereditary mutation or acquired wild type manifestation. Here's a schematic. I'm not going to spend too much time on this, but I kind of put a star here for the laboratory workup. Again, just kind of highlighting that it's critically important as part of a workup to rule out AL amyloidosis. Once you've ruled out amyloid or AL, you can just look at an echocardiogram. If you have strain imaging available at your facility, you can do strain imaging and look for apical sparing. There's potentially less amyloid deposition in the apex compared to the base. You'll see LVH with a lower normal QRS on EKG. You may see aortic stenosis, mitral valve calcification, and then diastolic dysfunction with a restrictive pattern of LV inflow. You can get a cardiac MRI. This is useful in patients that you're working up for HOCM or infiltrative diseases such as Fabry disease. You may see a thickened myocardium or late uptake of gadolinium on the MRI. You can get a technetium labeled pyrophosphate scan or PYP scan, and I'll get into this in a little bit, but it's useful in making the diagnosis of ATTR without a need for biopsy. And if you do confirm ATTR, you need to differentiate between hereditary and wild type with genetic testing. So this technetium PYP scan, it was initially used in the 1970s and 1980s in MI patients to quantify the degree of infarcted tissue due to calcified myocardium. It was resurrected in 2016 due to its affinity for cardiac amyloid deposits in ATTR. And then in the absence of AL, it's a useful tool for diagnosis of ATTR without a need for a biopsy. So here's a picture of technetium PYP uptake in the heart versus the lung. You want to get a heart to contralateral lung ratio calculating technetium pyrophosphate uptake in the heart. And so circle 0 on the right versus the contralateral lung on the left, which is circle 1 to account for any background due to ribs. And an HCl ratio greater than 1.5 is strongly suggestive of amyloidosis, but you still need to rule out AL. Here's another PYP scan. Technetium PY uptake in cardiac tissue compared to bone, and there's a grading system. You have grade 0 with no cardiac uptake, grade 1 with mild cardiac uptake compared to bone, or grade 2 is moderate uptake compared to bone, and grade 3 is high uptake compared to bone. And then grade 2 or 3 uptake is suggestive of ATTR, but you still must rule out AL. Here's another schematic of liver production of transthyretin. It's exists as a stable tetramer, and there's a potential treatment option called tafamidis, which stabilizes the TTR tetramer and prevents its degradation. The transthyretin amyloidosis cardiomyopathy clinical trial was looking at tafamidis, which is a pharmacological chaperone that binds to one of the 2 thyroxine binding sites of transthyretin and stabilizes the correctly folded tetramer, preventing degradation into amyloid fibrils. It was a phase 3 multi-center parallel design, placebo-controlled, double-blind randomized trial with 441 patients. It was 2-to-1, 80 milligrams of tafamidis, 20 milligrams of tafamidis or placebo. Primary endpoints were all-cause mortality or CV hospitalization, and secondary endpoints were the 6-minute walk test or the Kansas City Cardiomyopathy Questionnaire. So if you look at the top of the figure, this is looking at the primary endpoint of all-cause mortality and CV hospitalization, showing a p-value of less than 0.001. With the tafamidis arm superior to placebo arm with a win ratio, number of treated patient wins versus number of placebo patient wins. The all-cause mortality was lower in the tafamidis treatment arm compared to the placebo arm, and same thing for CV-related hospitalization. Figure B is a Kaplan-Meier curve illustrating reduction in all-cause mortality in the tafamidis treatment arm, with divergence noted at about 18 months after initiation of treatment. And then figure C is illustrating that patients treated with tafamidis had lower CV-related hospitalizations. Here we have a Cox proportional hazards model comparing different subgroups such as hereditary versus wild type ATTR, and among different NYHA functional classes with tafamidis versus placebo. It looks like it favors tafamidis with the exception of the NYHA class 3 patients. And perhaps this points to a need of getting to the diagnosis and initiating treatment early. And then this is just looking at secondary endpoints, least squares mean change in baseline for 6-minute walk test in the Kansas City cardiomyopathy questionnaire with divergence seen at about 6 months. So I have a case study. This is a patient, the reason I got interested in cardiac amyloidosis, I just had this patient in the clinic and I was just looking at her echo and just looking at her clinical history. And I started to ask myself, could this patient have amyloidosis? So she's a 61-year-old female, her past medical history, she has coronary artery disease. She had an NSTEMI with a PCI in 2005, unstable angina with PCI in 2017, type 2 MI in the setting of AVNRT in 2019 with an autoobstructive disease on her left heart cath at that time. And I referred her to EP for an AVNRT ablation. She had an EP study with our electrophysiology colleagues. They attempted an AVNRT ablation, but they weren't able to induce it, but they did induce atrial fibrillation and she was started on oral anticoagulation. She has bradycardia with bifascicular block, PAD, non-obstructive carotid artery stenosis, hypertension, hyperlipidemia. She also has lupus with CKD3A with proliferative glomerulonephritis, secondary to lupus class 3 with proteinuria and iron deficiency anemia. Some pertinent meds include aspirin, Eliquis, metoprolol, losartan, hydrochloroquine, Celsep, and prednisone. So she was admitted with AFib with RVR, associated chest pain. She converted on her diltiazem drip, but then she went into marked sinus bradycardia requiring dopamine infusion. She had intermediate troponins, which is consistent among multiple hospitalizations. And left heart cath was deferred because she was having nosebleeds and she was unable to lie flat, but she had a nuclear stress test without infarct or ischemia. Her echo, EF is 65% with moderate LVH with an IVSD of 1.6 centimeters. She has grade 3 diastolic dysfunction, severe left atrial enlargement, mild right atrial enlargement, aortic and mitral valve calcification, mild TR, and mildly elevated pulmonary pressures. So this is just her EKG when she went to the ER with AFib with RVR. And again, she was bolused with diltiazem. This is after her diltiazem bolus when she was requiring her dopamine infusion. This is one day when she just came into the office. She was on my schedule. I thought it would be an easy office visit, and my MA hands me this EKG. And so I walked into the room and she was hemodynamically stable. I mentioned that we should probably send her over to the ER, but she refused. So I gave her some water and sat with her and talked with her. And eventually she converted to a normal rhythm on her own. At that time, she was not on any chronotropic agent because of her history of bradycardia, but I gave her metoprolol succinate 12.5 milligrams once a day. Palpitations, she says have improved, but she remains bradycardic, and I have a suspicion that she's not really tolerating it very well. And this is just kind of her typical age EKG, sinus bradycardia with this bifascicular block. Here's a video of her echo. And if you notice here, I'm going to play a video in a second. You can notice LVH and some vascular calcification and an enlarged left atrium. And kind of has a speckled appearance to the septum here. And then the next video, there's a slamming door. So I apologize for that. Just an apical 4-chamber view. And this is just pulse Doppler measurements across her mitral valve and the apical 4-chamber view. As I mentioned, she has grade 3 diastolic dysfunction with a restrictable reversible pattern resulting in significantly elevated left atrial pressure. And I just kind of put a schematic here of kind of the progression of diastolic dysfunction, and she has grade 3. If you look at her E wave here, this is peak early mitral inflow velocity or early passive filling of the left ventricle and early diastole. And the A wave here is the peak late mitral inflow velocity or active filling or atrial contraction. We look at her EA ratio is greater than 2, which is indicative of grade 3 diastolic dysfunction. In her case, her EA ratio is 4.40. She has a tall, narrow E wave due to very high left atrial pressure and a very small A wave. And so we're seeing early, rapid ventricular filling secondary to that elevated left atrial pressure. Some lab work. So this is what I was working her up for AL. So she has some protein in her urine. Her free kappa and her free lambda light chains are elevated, but her ratio is normal. If you go back to that large schematic that I had up on screen earlier, abnormal ratio is less than 0.26 or greater than 1.65. Her IgA and IgM are low, but she does have an elevated M-spike protein. So there are multiple clinical features of this patient that raise suspicion for cardiac amyloidosis. She has LVH, she has atrial arrhythmia, she has underlying conduction disease, she has persistently elevated indeterminate troponins over multiple hospitalizations, and she has this diastolic dysfunction with this very elevated left atrial pressure. Some specific challenges in ruling out AL in this particular patient with laboratory workup, however. She has elevated lambda and kappa light chains and proteinuria. And this is, can be explained by her underlying renal dysfunction, but she does have a normal ratio of lambda and kappa light chains, which is encouraging in ruling out AL. She does have a low IgA and IgG. This is just kind of theoretical in my mind, but it could be rationalized by her immunosuppressive medication regimen. She's on hydroxychloroquine, she's on prednisone, she's on Cellcept. And she does have a positive N-spike protein, which needs evaluation by hematology. Is this a monoclonal gammopathy of unknown significance? A smolder myeloma? Is it multiple myeloma? So her nephrologist is kind of working with her for recently diagnosed iron deficiency anemia, and she was considering referring her to hematology. So I reached out to her nephrologist this week and sent her this lab work and spoke with the patient and advised hematological evaluation of this lab work. And just when I thought I was on the right path, working this patient up for cardiac amyloidosis, I came across this article a couple nights ago. Amyloid mimics remembering hydroxychloroquine cardiomyopathy. So that's another story for another day. So conclusions, amyloidosis is a disorder characterized by protein misfolding and pathological tissue deposition that affects multiple tissues and organ systems. AL and ATTR are the two most common types of amyloidosis with cardiac manifestations. We must rule out AL before pursuing ATTR. And cardiac amyloidosis is probably more common than we originally thought, or it is more common than we originally thought. It's nice that we have these technetium PYP scans to help aid the diagnosis, and making a timely and accurate diagnosis is imperative as treatment options are available. And these are my references.
Fantastic talk, Ron. Very detailed and extensive, covering from recognition to diagnosis, treatment, and a great case study. Thank you very much. Moving on to a different topic, we're going to talk about palliative medicine. And we have Hannah Farfour as our speaker here. Hannah is a board certified nurse practitioner and is currently a member of the palliative medicine team at the Mayo Clinic in Phoenix, Arizona, where she provides both inpatient and outpatient palliative care. Hannah also serves as a program director for the Hospice and Palliative Medicine NP and PA Fellowship Prior to her transition to an advanced practice nurse, she worked in multiple settings, including ICU, medical surgery, a surgical unit, and in management. She is passionate about providing high quality and compassionate palliative care to all patients in need. And when she's not working, she's a mom to 3 boys, ages 5, 6, and 9, and 2 dogs. She's happily married to an interventional gastroenterologist. Between her kids and the dogs and their specialties, conversation over dinner are delightful in their home. Welcome, Hannah.
Wonderful. It is so nice to be here and to be able to share something I am incredibly passionate about. It's really providing palliative care to our patients, and especially our patients in the most need. So I will be talking about, my title is Getting to the Heart of the Matter. It's providing palliative care pearls for you all, so that you can meet some of the symptoms as well as address some of the conversations that can truly influence an individual's quality of life. So I put my contact information here. So just in case you want to reach out to me after this presentation, I have my email address here at the Mayo Clinic. So I have no relevant disclosures. This is a true picture from Havasupai for my last hiking adventure. My objectives today are to help you recognize the role of primary palliative care within your cardiology specialty. I want to discuss the most common symptoms in advanced heart failure. I want to review the role of skilled communication and goals of care discussions. And I want you to be able to recognize the differences between palliative care and hospice care. So what exactly do I do? What is palliative care? And this is something I have to define on a daily basis with my colleagues, with my patients, with my friends. So we are a multidisciplinary specialty that focuses on optimizing quality of life and reducing suffering for patients and their families facing serious illness. And this is regardless of prognosis. So what I often find people think is palliative care equals hospice care. And I'd like to tell you now that they're not the same thing. Palliative care operates along a continuum, which ultimately leads to hospice care. So who provides palliative care? So I am a subspecialist. So we do have subspecialty management by a specialty trained provider who consults or co-manages palliative care, the needs along with clinicians who are managing the underlying illness. So primary care or primary palliative care is where the primary clinician, whether it's the internist, the cardiologist, the heart failure specialist, provides care in the palliative domains. So unfortunately, there's not enough of me. There's only one palliative care specialist for 12,000 patients. So that really means that our cardiology specialists, those on the front line, are going to need to be able to provide some of that basic and primary palliative care. So why do you need to do it? And I'm sure you all know this, right? Heart failure is a chronic, progressive, debilitating epidemic, and it affects greater than 6 million adults. It's the #1 cause of death. You see it every day. It has major physiologic and psychosocial burden. It causes significant functional limitations, and it has an unpredictable trajectory, and it's costly. So what does primary palliative care look like? So it comes to management of basic symptoms, communication on goals of care and advanced care planning, and psychosocial support, as well as care coordination. So this provides an excellent diagram of what, it kind of compares traditional heart failure management and includes what it looks like to include primary care. So it's what I just spoke about, kind of thinking about controlling pain and other symptoms. You assist with medical decision-making and advanced care planning. You assess and reduce emotional distress and burden to patient and family. You coordinate care across the patient's trajectory, and you promote improved quality of life for the patient and the caregiver. And certainly the specialist in palliative care remains available for any of those complex cases. So I often, even within the subspecialty of palliative medicine, I'm just surprised at the symptom burden of our patients with advanced heart failure. I sometimes focus on my cancer patients, but I forget, my goodness, my cardiology patients with advanced heart failure, pain is present in 78% of them. 61% of them have shortness of breath. There's depression and anxiety, which is very prevalent. They have difficulty sleeping, appetite just doesn't exist, and there is widespread fatigue and debility. So how do we treat it? So peripheral edema, osteoarthritis, neuropathy, sometimes as a cardiology specialist, you may shy away from this, but even simple recommendations as acetaminophen or a single agent opiate management can be quite helpful for managing these symptoms, because we know NSAIDs and some of the other interventions are often contraindicated. Certainly, you know how to manage angina very well. Referral to physical therapy can often be helpful for the chronic pain. And really, you may need to advocate that they regularly see their PCP or even integrate into a chronic pain practice who is specialized at managing these symptoms. So shortness of breath is incredibly common. Often we like to maximize the heart failure management. And believe it or not, low-dose opiates are the first line management for refractory symptoms. And often we go to low-dose opiates prior to going to benzodiazepines or other classes of medications because they work well, and often it's at lower doses than you would have for pain. Fans can be very helpful and often aren't thought about. So for depression and anxiety, just being able to identify it and make the appropriate referrals so they can get the help and support they need. If you consider starting an SSRI, sertraline is the most studied and often the safest for the management of depression. Nausea, certainly we know this is very common. You can adjust the heart failure therapy, but consider your single agent antiemetics such as ondansetron or Zofran and haloperidol. I will say, I know my cardiology colleagues, and they're so good at monitoring QTC. Go look at the data on how ondansetron and haloperidol affects QTC. We find that it's dose related. So the low doses used in regular nausea management are often safe and haven't had a significant effect on the QTC. So fatigue, we would maximize heart failure therapies, refer to cardiac rehab, evaluate and treat insomnia, evaluate for sleep disordered breathing, and insomnia, educate on sleep hygiene, and treat mild anxiety-related disruption with psychotherapy or relaxation techniques. And certainly you can provide referrals for both of these. So here's the hard part. And I think communication can be the most difficult thing to do with our patients. How do we do it? How do we do it correctly? How do we keep the patient from getting angry with us or really having consequences that we weren't intending? So some of the things you do have to communicate as a cardiology specialist could be a prognosis. I want you to feel comfortable in engaging in advanced care planning. You'll have to talk about discussions to withdraw life-sustaining therapies, whether they be LVADs, even defibrillators, there are many interventions, and discussion of code status. So prognosis. This, I think, is a very helpful figure. Look at the blue line, right? This is what we typically sense as our trajectory for our cancer patients, right? You keep going, you're doing pretty well, and then all of a sudden you get stage 4 cancer, everything metastasizes, and you kind of start having a significant drop. Timeline to be determined by treatment. Certainly immunotherapy has effects there too as well, so kind of change this trajectory a little bit. But if we look at this red broken line, kind of an organ failure, this is what our patients with advanced heart failure experience, right? You're doing pretty well. Oh goodness, you had an exacerbation, you declined, you get a little bit better, but you never come back up to where you were before you were diagnosed. So this can continue for an indefinite period of time. And often our patients with advanced heart failure, they can have sudden cardiac death, or they can have a slower decline. So this is a tough one. So for prognostic pearls, certainly we have the Seattle heart failure model, which is very helpful. You can just plug in different pieces of data and get a sense of what the predicted morbidity and mortality would be. We also know that heart failure with a preserved ejection fraction as well as reduced ejection fraction have similar morbidity and mortality. So your median survival is 2 years after diagnosis. Recognizing that greater than 1/3 of patients hospitalized with heart failure die within a year. So I think this is an important thing to consider. And I really want my primary cardiology specialist to share with patients that they have a high risk of sudden cardiac death. So that way patients are aware and they can plan accordingly. One thing I want you to remember is accurate prognosis is virtually impossible in heart failure. So grant yourself a pass a little bit there. And what we've seen has been the most helpful question and probably the simplest to implement is, would I be surprised if this patient died in the next 6 months? And if so, I think it's time to have a conversation. So advanced care planning, I recognize that this can be a cumbersome task. It's something we don't necessarily think about. We all need to do it. And it's really about having conversations with our patients about what their wishes and preferences are and actually documenting it, whether that be through an advanced directive, through the EMR. And these conversations happening early, often, and with any transitions in care are recommended. I recommend that all of you get formalized communication courses or attend them. These are such as cardio talk or vital talk. Communication skills don't happen overnight. They are integrated into your practice over time. And I promise you it will change your interactions with your patients, but also your family members. There's some pretty nifty tools on how you can really identify emotion and engage in meaningful conversations with all around you. So throughout advanced care planning, you do things like explore goals and values, you share prognosis, you help identify a surrogate decision maker, you can provide guidance on how to complete an advanced directive. And certainly if cardiac devices that can prolong life are offered, you need to have discussions about deactivation as well, because that is an important conversation to have, to set expectations, recognizing that, hey, this can give you time, but at the same point, this doesn't contribute to immortality, right? We're all mortal, so there will be a time when this device is not offering benefit and or value. So I had spoken about what I recommend you do after kind of attending our lecture today. Here are those resources for Vital Talk, for CAPC. There's an EPIC program. There's an end-of-life education project. And then palliative care fast facts are excellent. It's an evidence-based one-sheet tip and trick tool so you can really integrate palliative care in your practice. And then back up to CAPC, they actually offer modules where you could actually go through modules where you can gain communication skills, but also primary symptom management skills. So when we have those medical intervention discussions, we know that before meaningful decisions can be made, that the patient and or family need to have a realistic understanding of the medical condition, the prognosis, and the consequences of starting or stopping an intervention. And oftentimes this is hard to assess, but I recommend that all of us do so. And then also understand the risk and benefits of any of the interventions that you're offering, right? We all know how many times that information has been shared with patients, but we have identified a gap. Well, are we sure they understand? What did they miss? Why are they not doing what I asked them to do? Or, you know, there's a huge gap there in much of our patient interactions. Some of the questions we could ask are, what do you understand about your prognosis? What do you think the side effects or consequences of the intervention might be? And at what point would you consider stopping the intervention? Would it be if it caused symptoms, postponed dying, required replacement, or failed to provide good quality of life? So this right here, this is your roadmap. Go to Google, look up Aranande Labs, and this is your roadmap for a serious illness conversation guide. This is patient-tested language. It'll talk about statements such as I wish and I worry. And I promise you that using a guide like this will make these conversations far easier. And it also takes practice to integrate. So I give this to all of my residents, all of my learners, anyone who comes on service with me, and it's amazing to see how it changes practice. So this is the hard part for some of us, talking about code status, and not all of us have the opportunity to do so. But if we're having those bigger goals of care conversations, I recommend that you have a discussion specifically about the documentation of code status. Certainly you want to have this conversation within the overall prognosis of a patient. I want you to remember that CPR will not improve functional ability, restore health, and will most certainly decrease it. Survival to discharge after in-hospital CPR is 6 to 15%, and survival and out of hospital arrest is less than 10%. And certainly feel comfortable to make a recommendation and document it in the EMR. And here in Arizona, if someone elects to have a DNR, then I recommend that they have an orange form completion. And this is just documentation of the DNR status for the outpatient arena. So if they were at home, they were found down, then they would not have CPR or intubation attempted or kind of rushed to the emergency room in kind of the same fashion. So one phrase that I think could be very helpful is when you die, your heart stops and you stop breathing. At that point, would you want us to attempt to allow, or would you want us to allow natural death or attempt to resuscitate you? You know, I think this changes the tone and how we discuss code status, right? It's not saying, you know, if we are attempting, if we're doing CPR, that's just part of the big picture plan. We think it's going to work. It's like we are providing, you know, optimal management of heart failure. This is something that's different, right? If they've progressed to the point where their heart stops and they've stopped breathing, things have changed. So I think this phrase actually represents that tone and kind of can lead you to more meaningful conversations and decisions. So primary palliative care, this is kind of the cardiology specialist domain, right? Patients with clear wishes and an understanding of prognosis of CPR, patients with clear wishes and can identify a surrogate, and patients and or surrogates who have clear understanding of prognosis with and without the therapy that can make decisions. Now we talk about psychosocial support and care coordination. So caregivers of patients with heart failure have a huge burden. It would be incredibly helpful if you were able to identify suffering from anxiety, depression, and complicated grief and refer them to the appropriate resources, such as social workers or chaplains. And engaging in those frequent goals of care conversations, those can happen annually and or a change in the clinical condition. Your community resources. There are a number of community palliative home care programs these days, one of which we use often here at Mayo Clinic is actually the Medicaring program through Hospice of the Valley that had initiated as a pilot program, but now has been a great resource for our patients with advanced heart failure in the sense that they can continue with their specialty care, but still get the people support of hospice. But there are multiple other agencies that can provide that as well. So we have subspecialists in palliative care, but I recognize that their access may be limited. I know we are a little spoiled here at Mayo because I know my heart failure colleagues are able to refer to us, but there are a number of palliative care specialists within the community as well. And then there's hospice care. And this is something I wanted to spend a little bit more time on because I often find myself attempting to share what hospice is and really what hospice is not with many of my colleagues as well as my patients. So hospice is a model and philosophy of care that focuses on providing palliative care to the patients with life-limiting illness, focusing on palliating patients' pain and other symptoms, attending to their and their families' emotional and spiritual needs, and providing support for their caregivers, right? So it's very similar. It actually is within the domain of palliative care. I call it the insurance benefit, right? It's the insurance benefit when you have a prognosis of 6 months or less that can provide actually a lot of support. So it has an interdisciplinary hospice team. So you have your physician, your nurse, your social worker, your chaplain, your bereavement coordinator, and you also get a little bit of extra help, whether it be through volunteers or hospice aides. So who qualifies? So this is who qualifies in advanced heart disease. So you have to have CHF, New York Heart, sorry, I'm stumbling, class 4 significant symptoms at rest, and the inability to carry out minimal physical activity with shortness of breath or angina, and optimally treated with diuretics, vasodilators, hydralazine nitrates, or you can have angina at rest, but it's resistant to standard nitrate treatment and either not a candidate for or declined invasive procedures, right? So your supporting documentation has to include an EF less than 20%. They have to have treatment-resistant symptomatic dysrhythmias. You have a history of cardiac-related syncope, your CVA, status post-cardiac embolism, history of cardiac resuscitation or concomitant HIV. So it's actually harder than we kind of think about in getting a patient into hospice, but if you have any questions, provide the referral, right? And so it could be the hospice agency to tell you whether or not a patient qualifies. And many times I see hospice agencies doing their best to find a way to have a patient qualify for that insurance benefit. So some of the benefits of hospice: psychosocial, spiritual, and symptom support. You have some support in the home. You have the potential for short-time intensified care within inpatient hospice units, and some patients do qualify for respite care as well. You have medical equipment, supplies, and medications delivered to the home. You have bereavement support, and patients often have at home expert symptom management and support. So, and that can also, their end of life could also happen at an inpatient unit. So this is what I often try to dispel. What are the limitations of hospice? A hospice is not a 24-hour facility to provide care at end of life. I wish we had that. So we don't have the ability to provide custodial care. It doesn't provide 24-hour caregiving. You can't get frequent transfusions of blood products. And due to reimbursement, patients may be limited from seeing outside providers and seeking palliative interventions. Our larger and non-for-profit hospice agencies may be more flexible in paying for quality of life interventions, such as routine lab work, Florex catheter placements, or really anything that is directly related to a patient's symptom burden and overall quality of life. So if you think that a patient would actually benefit from hospice, what I often recommend is you talk about the services that they would receive before saying the word. So for example, it sounds like it is becoming more difficult for you to come to your appointments, and you do not like being hospitalized. It might be easier for you to have a nurse visit in your home and have medications delivered to you, and hospice would be able to provide this service. So I covered a lot today. My final pearls, though, is really I wanted to make you aware that there are resources for you to acquire skills in primary palliative care. As mentioned earlier, that's through CAPC, there's specialty training through LNEC or EPEC. I recognize communication is so hard, and that communication and gaining these skills doesn't happen overnight. Vital Talk serves as an excellent resource. There's an app for that, which I find myself even 5 years in and going through the app on how to have really tough conversations. I think it's really important to be able to talk about what hospice and palliative medicine is and is not, because often I find that patients don't truly understand what these are, and it may lead to decisions that ultimately affect their quality of life and potentially length of life. And so if you need support in doing all of this, there's certainly community-based referrals and referrals kind of to our academic centers or kind of our specialty programs within the Valley area. I so appreciate your time. I'm always available for help and support and this very, very important task of really making our patients' lives better.
Thank you so much, Hannah, for joining us today. I was taking notes. I think that palliative medicine is definitely underutilized by us taking care of our advanced cardiac patients, but offers so much. Our next speaker is Kristen Babb. Kristen is a physician assistant working on the EP team at Banner University Medical Center. She spent 13 years working in private practice cardiology before joining the academic center. She is the founder of the Cardiology Advanced Practice Providers, which is also known as CAP, a local networking organization that supports and empowers PAs and NPs working in cardiology. We want to welcome Kristen, who's going to be speaking on an interesting case in EP.
Our next speaker, we'll get back to Christine once her slides are ready, but I'd like to introduce a friend and a colleague, Dr. Dan Saraja. He's a electrophysiologist at the Mayo Clinic, and he's currently the program director for the Mayo Clinic Arizona EP Fellowship. He is also the associate program director for the Cardiovascular Disease Fellowship at the Mayo Clinic. Welcome, Dan, and we're honored to have you speak at our meeting.
All right, thanks for having me. Let me see here. Can y'all see the slides here?
Yes.
Yep. Good. Okay. All right, we got a lot of slides to cover. It's fundamentals of ECG. To put in perspective, we do 10 lectures about this for the internal medicine residency, and we give another 4 lectures for the medical school. So we've got a lot of material, so we're just gonna fly through this. And if people have questions at the Q&A, we can go over whatever additional. All right, mandatory Chuck Norris slide. I've had a Chuck Norris slide for 17 years. We're not gonna stop today. So when we think about
Hey, Dan,
yeah.
I don't think the slides aren't advancing.
Oh, they're not? So you don't see this? Let's see.
I just see fundamentals of EKG.
All right.
ECG.
You see that? Where it's moving?
Yes. Yes.
Oh,
Now it's working.
okay. I wonder what happened. So here's our mandatory Chuck Norris slide. So when we think about reading ECGs, there are 2 ways we think about it. Usually, as people are learning ECG, we go through these branch points and we come up with what is going on with the ECG. But as you keep reading enough ECGs, you'll get to the point where you look at it and you'll be like, yep, that's an elephant. You don't have to think about it. You can see it from different angles and you still get to the same answers. And that's where we typically want people to get as they get comfortable with it. So how is the ECG constructed? There are 2 leads or 2 poles of the ECG lead. One is going to be negative, one is going to be positive. And as we depolarize the heart in the direction of a positive terminal, we're going to get a positive deflection. If we kind of deflect towards that positive terminal, we're going to get less of a positive deflection. If we go perpendicular to this axis, say this is lead 1 where your right arm is negative and left arm is positive, you're going to get no deflection here. Now, if we depolarize the heart away from that positive terminal, we're going to get a big negative deflection. If we kind of depolarize away from a positive terminal, we're going to get kind of a negative deflection. And then if there's no current, it looks just like if the electrical activation was perpendicular to what we're looking at. And kind of a nice way to think about it is like a cop's camera or radar gun. If you're going directly in line with the gun, you're going to get a higher speed compared to going perpendicular to it. It's not as accurate. Now, here are how the leads are configured. So for like lead 1, the left arm is positive, the right arm is negative, and we're watching the electricity go from this right arm to the left arm. As you can see from lead 2, it's right arm negative, left foot positive, and then for lead 3, left arm negative, left foot positive. To make AVF, AVL, and AVR, we turn 2 of the leads negative and 1 of the leads positive. So like for AVF, the right arm and left arm are negative and the foot is positive. And we try to watch the electricity go towards this one channel. But what happens is the electricity kind of cancels out. So we actually have to turn up the signal, and that's where we get this augmented voltage foot. And that's the same reason we get augmented voltage left and augmented voltage right. So here it is kind of in summary for unipolar leads. It's very similar. So all of the chest leads like V1 through V6, or if you have V7 through V12, like on a posterior ECG, if you go towards that unipolar positive terminal, we're going to get a big deflection up. And then if you go away from that terminal, so here's the terminal and we go away from it, we're going to get a negative deflection. And sometimes as we go towards it and then away from it, we're going to get that positive and negative. And then you can imagine the corollary of that, where we're going away from a positive terminal and then towards the positive terminal, we're going to get this negative and then positive deflection. So here it is in a summary slide. It's much easier to memorize depolarization, and then just remember repolarization is the exact opposite. For an ECG layout, this is how it looks. It's all blown up, and usually you are able to see these big boxes. These big boxes are about 200 milliseconds, and they're subdivided into these small boxes, which are 40 milliseconds. Each of these boxes is also 1 millimeter tall. But if you put these 5 small boxes of 40 milliseconds, you're going to get that 200 milliseconds. And if you put 5 big boxes together, you get 1 second. And just to show you how much we blew it up here, here's a typical rhythm strip size on an ECG. So this is how it usually lays out on most people's ECGs. This is 10 seconds of monitoring, and we divide it to where the limb leads 1, 2, 3, RLF are here on the left. And then the precordial leads V1 through V6 are here on the right. And we basically subdivided into 2.5 seconds for each of the leads. So you get 10 seconds total. All right, so here's one way you can use to interpret an ECG. And if you notice, the very last step is determining the heart rhythm, but we're gonna just walk through all of these steps talking about normal and abnormal. So the easiest way to calculate rate in case the ECG is doing something wonky is to just calculate whatever you want to know about. So like here, if we're wanting to know what the heart rate or the ventricular rate is, we count the ventricular rate. And on this one, there's 15, and we know there's 10 seconds. So to get to 60 seconds, we would multiply 10 times 6. So here with 15 QRSs, multiply by 6, and the heart rate is 90. Here's the alternate way. This is how electrophysiologists like to calculate it. We know 60 seconds is a minute. And if you divide that or change the unit to milliseconds, that's 60,000 milliseconds. And so like here, we can measure the time between whatever we're measuring, in this case, the QRS. And this is 3 big boxes and 1 small box. So that's 640 milliseconds. If we divide that into 60,000 milliseconds, we get this heart rate, and you look really cool because you're super accurate. So let's take a look at the P wave. The P wave, these are round and smooth, and this is the atrial activation. Usually it has this axis of 0 to 75 degrees because the heart is being activated right to left and top to bottom. So it's usually upright in 1, 2, and AVF for the sinus P wave. There are places that it can come from outside of that sinus location, and usually those are either negative or narrower, depending on where they come from. So here's that idea where the heart is got the atrium on top, ventricles on bottom. And if the sinus node, which is where the superior vena cava comes into the right atrium at the lateral side, fires, it literally has to go all the way to the left, and it has to go all the way down. So we would expect activation to be positive in 1, 2, and F. All right. Here's a nice old article from 15 years ago talking about where people get other rhythms that are not sinus. And you can see the bulk of them are from the right atrium and less so from the left atrium. But the idea, if you're trying to figure out where they're coming from, the further over in the atrium you are, the more you have to activate the right atrium and then the left atrium. So you get kind of this double hump configuration because of this crista terminalis. And then if you were to activate from the middle of these 2 chambers, what's going to happen is you're going to activate the right ventricle or right atrium at the same time you're activating the left atrium. So this atrial activation takes less time because you're doing it simultaneously. If you're coming from the top of the heart, this is going to be upright in the inferior leads like F and lead 2. Whereas if you're coming from the bottom of the heart, it's going to be inverted, as you can see here. So just to show you, here's an ECG that is sinus rhythm, and we have a P wave that's upright in 1, 2, and F. So this would be sinus, or red is sinus. Just to show you an example of a low atrial ectopic rhythm, here we have a P wave that is clearly inverted in 2, 3, and F. So this is not coming from the sinus. This would be probably coming close to the coronary sinus. Here's another type of ectopic rhythm that isn't the sinus. This is multifocal atrial tachycardia. This is where there's more than 3 P wave morphologies and the heart rate's over 100. This is most commonly seen with pulmonary disease. you can see this person has 6 different P waves that are color coded, and you can kind of guess this is where they're coming from in this person's right atrium and left atrium. What if there's no P waves? Typically, the 3 things that cause that are atrial flutter, atrial fibrillation, and junctional rhythm. You can also see that with ventricular tachycardia in 30% of the time. So atrial flutter, particularly typical atrial flutter, is going to have these sawtooth waves I'm going to show you. For atrial fibrillation, there's no clear P waves, but there are fibrillatory waves, and these don't have any clear relationship to the QRS. So let's take a look at those. So here's atrial fibrillation. Now you may look here and say, well, that looks like atrial flutter because look at these kind of fake sawtooth things. But atrial fibrillation can sometimes organize into what looks like atrial flutter. But if you look just a little further over, you can see these fibrillatory waves are definitely more disorganized than the left side of the ECG showed, and that these RR intervals are varying quite a bit. So this is atrial fibrillation every day of the week. And the idea is there's multiple wavelets in these upper chambers. And when they get to this AV node, it kind of bombards the structure and it takes the atrial activation down in a very sporadic form, which causes these irregular QRSs. Here's typical atrial flutter. A lot of people like to call these shark teeth, sawtooth, anything regarding very sharp things. And what happens is the electricity has to spin around the tricuspid valve as well as come around the crista terminalis. And every time it comes all the way around that circuit, it hits the AV node and it asks the AV node, are you able to take this electricity down to the ventricle or not? And usually it takes 2 to 4 turns around the circuit before the AV node will take it down. So most commonly, you're going to see heart rates of 150, 100, or 75, which correlate to 2 to 1 block, 3 to 1 block, or 4 to 1 block. All right. Now, if the AV node kind of works not as well every time, it can be irregular, but frequently it is regular, and you may miss it on physical exam if you don't have an ECG. Just for completeness sake, here's junctional rhythm. You can see there's no P wave here. We just have narrow QRSs marching out. So let's talk about some atrial abnormalities. I would encourage you to avoid the phrase right atrial enlargement. There's data to show that the chamber doesn't have to be enlarged, but you may get these conduction abnormalities. So for right atrial abnormality, this is where the P wave is really tall in the leads 2, 3, and AVF for these inferior leads. Left atrial abnormality is where in V1, you have a wide P wave that is more than 1 box deep and more than 1 box wide, 1 small box, I should say. So let me just show you what those look like. So here's right atrial abnormality. If we focus our attention on these inferior leads, 2, 3, AVF, you can see this P wave is really quite tall, over 2.5 millimeters or 2.5 small boxes. Here's left atrial abnormality. As I showed you with that Kistler diagram, we have to activate the right atrium and then we have to activate the left atrium. So you get this bifid configuration in lead 2 most usually. And then over here in V1, this negative component to the P wave is going to be more than 1 small box wide and more than 1 small box deep. This one's about 1.5 boxes, as you can see there. All right, let's look at the PR interval. What is the PR interval? It's the P wave plus this PR segment. Segments are usually between 2 waveforms. Intervals include a wave plus something else on an ECG. And this represents the time it takes for the atrial depolarization to the onset of ventricular depolarization. So this is kind of where the heart is maximizing that filling of the ventricle before ventricular depolarization. Normally, this is 120 to 200 milliseconds or 3 to 5 small boxes. Sometimes you'll see it quite short, and that gets people very excited because they start looking for things like Wolff-Parkinson-White or an accessory pathway. In young people, it can just be due to their AV node conducting quite fast. And sometimes it's just due to premature ventricular complexes or junctional beats that are beating out the intrinsic rhythm. When that PR interval gets over 1 big box, this is usually first degree AV block. It's really not a block though, it's conduction delay because all the P waves conduct to the ventricles. Then anytime you see the PR interval quite long, look out for complete heart block. Usually you'll see the PR interval vary throughout the ECG. So let's take a look. So here's a normal PR interval. You can see this P wave to the onset of this QRS is clearly less than 1 big box. This is about 120 milliseconds here. Here's a short PR. You can see here the P wave to the onset of the QRS is really less than 120 milliseconds. And there's this funny slurring going on. It doesn't look like a normal QRS. And this is pre-excitation. This person had a posteroceptal pathway reablated. How does that work? Well, here's our construct where the superior vena cava comes into the right atrium. So here's our sinus node. And when the sinus node fires, it goes to the AV node here, but with an accessory pathway, the electricity also comes to here. And what happens is there's no delay in the accessory pathway, whereas the AV node has a built-in delay to maximize atrial emptying of blood into the ventricle. So what happens here is the electricity comes down this accessory pathway and starts to depolarize the ventricle, and that gives you this delta wave. But then as the electricity is able to get past that delay in the AV node, the normal electrical system conducts 10 times faster, and that's what gives you this sharp QRS afterwards. So what we're seeing is a fusion of the delta wave followed by the electrical system taking over with pre-excitation. So here's a short PR from junctional rhythm. You can see this P to R is really quite short. It's less than 60 milliseconds. So this P wave is probably not causing this QRS because physiologically it wouldn't help to have it this short because the atrium wouldn't dump blood enough into the ventricle. And there's no slurring here. So this is how you tell it apart from pre-excitation. Basically, we have a short PR. It's less than 60 milliseconds and there's no slurring. Here's the exact opposite. There's the first degree AV block where the PR interval is greater than 1 big box or 200 milliseconds, and every P wave conducts to a QRS. So this is what we call first degree AV block, but again, it's not really block, it's really just conduction delay. So let's look at some variations of this. Here's a variable PR interval. This is everyone's favorite ECG, I think. This is second degree AV block type 1. This is due to most commonly conduction issues in the AV node. And what happens is if we look at this sinus P wave and the PR interval, as we go through this group of QRSs, it's going to get longer. So here this PR is getting longer, this PR is getting longer, this PR is getting longer before this P wave doesn't conduct to the ventricle. And this next P wave is going to conduct with a shorter PR interval. And that shortening when it starts conducting compared to the last time it conducted before it's blocked, kind of tips you off this is wanky bot. We then name the group based on how many P waves there are for the QRSs. So here's 1, 2, 3, 4, 5 P waves, and here's 4 QRSs. So this is a 5 to 4 group. As conduction gets worse, these numbers get lower. So 4 to 3 would have worse AV conduction than 5 to 4. And then 3 to 2 would have worse conduction than 3 to 2, just to put in perspective. Here's complete heart block. This is where the P waves are kind of going at their own rate. And then the QRSs don't really care what's going on. So they go at their own rate. And so this is AV dissociation. The P waves are faster than the ventricular rate. All right, let's look at the QRS complexes. So the QRS, it's named a QRS, even if there isn't a Q, even if there isn't an R, or even if there isn't an S. This is basically the beginning to end of ventricular activation, but theoretically, ventricular activation goes all the way to about halfway through the T wave, if you wanted to know. So how do we name it? It depends on how many waves there are. There's monophasic, where there's either a very positive deflection that we would call R. The predominantly positive wave is always called R. If there's only one wave and it's negative, we call that a Q. So if it's the first thing that is negative, we call it Q. So that brings us to biphasic, where there's two waveforms being positive and negative, or negative and positive. So again, this would be an RS because the predominant R wave would be called R. And this negative deflection follows R, so that makes it an S. Whereas this one is negative followed by positive. So the first negative wave is going to be called Q as long as it's in front of the R. And since this is the predominant positive deflection, this is called R. So this is QR. And then here's triphasic. So this is RSR prime. Why is this one R prime and not this one? Well, this is the first positive R wave, and that's how it's named. You can also see in the literature lowercase r's, lowercase q's, and that's just trying to put in perspective the size of the R wave or Q wave in relationship to the other waves. So the normal QRS, so this is the start of ventricular depolarization. Usually it starts out negative and becomes positive on the ECG around V2 through V4. If most of these are about 60 to 100 milliseconds, they can be up to 120 milliseconds before we start seeing bundle branch block. Just to show you normal activation. So here's someone's planking, they're face down, and here's their back. The heart normally electrically activates around to the side and then comes back like this. And if we imagine this headless person facing you, the electricity is going down and to the left and then up and to the right. Let's imagine a person had a big heart from hypertension or something like that. You can imagine that left ventricle is going to be here in the back and over to the left. So this electrical activation is going to be making this bigger circle. And then here it's going to go more down and more to the lateral before it comes up. How does that show up on an ECG? This is the criteria we teach our fellows, this Cornell criteria. This is the one they need for the board exam. And what we do is we look at this S wave in V3, so this negative deflection here, and then we add it to the positive deflection in AVL. And for men, if it's over 28, we call that LVH. And if it's over 20 in women, we call that LVH. All right, let's talk about some conduction abnormalities. So normally when the heart goes, it fires from here, it goes to the AV node, and then it goes down both the left bundle and the right bundle to activate the ventricles. But sometimes one of these bundles or branches are knocked out. And what does that look like? So here's the right bundle branch block. We can still get our sinus node firing. It comes here to the AV node. And because this right bundle is knocked out, the electricity all has to come down this left bundle. Well, we can't leave this right ventricle not activated. It has to depolarize as well. So what happens is electricity spins around, comes around the back, and then gets the right ventricle. All right. What does that look like? Here we can see here it's coming down this left bundle and it swings around all the way around the back and to the front. And that gives you this RSR prime in V1, or the rabbit ears as people like to say. And usually you're going to get an S wave in V6. When we map this in electrical systems in EP, what does it look like? Well, here is that early activation on the septum. It's swinging around the back. It's coming around the back to the right ventricle and coming around like that. You can see here there's some leakage across the septum, but this is how it predominantly is activated. This is what it looks like. So here we have our RSR prime with our little S wave in V6, and the QRS is over 120 milliseconds. All right, let's do the converse of that, left bundle branch block. So we have our sinus node firing. It comes to the AV node and it finds that this left bundle, including the left interior fascicular and left posterior fascicular, is knocked down. So where is all the electricity going to go? It's going to go down this right bundle, right? And then it's still got to go get the left ventricle activated. So it's going to swing up and get that left ventricle and then come right back around the back. All right, what does that look like? Here is that activation. You can see here, the left bundle is knocked out, goes to the right ventricle, and then it swings all the way to the back and back to the left. On our mapping system here, you can see here, the the mapping system uses a rainbow system like Roy G. Biv. So red is the earliest and violet is the latest. So here we're getting that right ventricle activated, and then it comes back across the septum to the back of the left ventricle and swinging around the back. What does that look like on an ECG? We're going to get this big negative deflection in V1, and we're going to get a big positive deflection in V6, and there won't be any Q wave here in the front of V6 because the septum is not being activated by the left bundle. Here it is in a big ECG, where here we got that QS configuration. You can have a tiny R with a big S as well, and here we don't have any septal Q. Another big sign to look for is notching. You can see here there's a really delayed intrinsicoid activation of this V6, and here's some notching in AVL and 1 that suggests this is true left bundle branch block. The left bundle does have 3 components: left anterior, left posterior, and left septal fascicles. And what is a combination block? A combination block is where you have the right bundle plus a block in just one of these fascicles, usually left anterior and left posterior. The septal fascicle is much harder to see and sometimes not visible at all. Some people ask, well, can you have right bundle and left bundle branch block? Yeah, you can. That's called complete heart block or asystole. Some people like to also use the term trifascicular block. I would encourage you not to use that term. Trifascicular block historically is first degree AV block plus one of these left fascicles block plus right bundle branch block, but it's kind of a meaningless term that doesn't tell you about the pathophys, so try to avoid that term. So here's our rabbit ears in V1. So you can see here, there's a right bundle branch block. Left anterior fascicular block is usually seen with a tiny R with a big negative deflection in these inferior leads because the electricity goes to the bottom of the heart and then has to spend all of its time going to the top where the anterior fascicle is knocked out. On the converse, again, here's right bundle branch block, and now the electricity for left posterior fascicle block, it's knocked out. So the electricity initially goes away from the inferior lead to get the top of the heart, but it spends the bulk of its time going towards the bottom. So you get this QR pattern in the inferior leads. All right. So what leads look at what? Here's that layout: 1, 2, 3, RLF, and our precordial leads V1 through V6. The bottom of the heart or inferior leads are typically looked at by 2, 3 AVF. And for the lateral leads, remember V1, lead 1's on the side of the heart with AVL, and V5 and V6. Anterior would be just in front of that, so that's V3, V4, and then V1, V2 are what we call anteroseptal. All right, just to show you some of that activation and how does that work. So if you've ever seen an inferior heart attack, usually they've got these Q waves that are in 2, 3, and AVF, and these are going to be at least 1 small box wide, and they're going to take up 1/3 or 1/4 of the size of the QRS. So activation wise, this is actually what it does in the heart based on some really nice vectorgram work from Brazil. But this is what you're typically going to see: big Q waves, and it's almost taking up 1/3 of the height of the subsequent R wave. Just to show you an anteroseptal infarct. So those anteroseptal leads are V1 and V2, and we usually add V3 here. And so what's happening here is we're not generating any upright activation. This tissue is dead, so that activation is going more backwards from the heart. And you can see here, we don't really get an early transition in the R wave. Usually the QRS is going to be positive somewhere between V2 and V4. And so we get this delayed transition here in V5. But these Q waves in V1 through V3, this is old anteroseptal infarction. For anterior infarction, we're now infarcted more of the anterior myocardium. So you can see here, V2 through V4 are clearly negative. We've got these big old Q waves, and the transitions even later here in V6. And that's because all of this tissue is dead. And so the heart can't go over there to activate it. So it actually goes more posterior for the activation. Just to show you comparison, here's anteroseptal. If you look here, it's still able to go a little bit lateral, but then here anterior infarct, there's no dead tissue here, so it's going more posterior. All right, so here are axis, normal axis, as you would expect, going from right to left, top to bottom. We're going to get QRSs that are positive in 1 in AVF, because 1 is over here, F is over here. This is right superior axis. Most people like this axis because it helps them figure out if it's VT. Some people call this northwest axis, and people know what you're talking about, but we don't call this southeast axis. So it's kind of got its own weird name, being northwest axis, but right superior is technically correct. All right, so let's talk about the ST segment. The ST segment is the end of ventricular activation and beginning of ventricular repolarization. It's called the ST segment, whether or not there's an S wave at the end of the QRS, even if it's an R or a Q, we still call this by convention the ST segment. Why is the ST segment important? We look at deviation in here to say, is there ST elevation versus ST depression, or is it basically flat? And we compare it to two areas. One would be this TP segment, which is between the end of the T wave to the start of a P wave. Technically, there's no atrial or ventricular activation going on here. So there's this used to be the isoelectric line. But about 2 or 3 years ago, the ACC and American Heart Association decided to start using this PQ junction point as the isoelectric point, particularly for rapid heart rates where this segment may not be visible and people are moving. So this is now used as the comparison for saying, is this ST segment elevated or depressed? Just to show you some variations. So concave upward is this kind of scoop or ladle configuration, whereas this convex is this kind of tombstone look to it. ST depression, here you can have horizontal, you can have down sloping, and you can have up sloping here. What are some things we should talk about? The J point. The J point is where the QRS meets this ST segment. This is not related to the J waves like Osborne waves and early repol. I'll show you some examples of that later. Now, let's say you do see ST segment elevation. The most common thing you got to worry about is infarction and then pericarditis. In old infarcts, you can see aneurysms, but here's some other things, early repol, Brugada. There's lots of other things, but these are the main ones. For depression, it's most commonly ischemia or medication, but if a person has LVH or ARVC or arrhythmogenic right ventricular cardiomyopathy, you got to be looking for things like that. So let me show you some examples of this. So if we have ST elevation, this translates to an acute infarction. In this case, this is an acute inferior infarct. So we're going to look in the inferior leads being 2-3 AVF. And here we see ST elevation here in 2-3 AVF, and looking at our ECG map of 1-2-3 RLF and V1 through V6, here the inferior leads all have ST elevation. So again, ST elevation means acute, and here we're going to look in the anteroseptal leads. We have ST elevation in the anteroseptal leads, which are V1 through V3, and you can see here this person has some badness, probably in their left main, maybe proximal LAD. They need to go to the cath lab with Dr. Lee. So here's ST elevation in the anterolateral leads. So you can see here, anterior is V3 and V4. Usually we include V2 as well. And then here's the lateral leads, V5, V6, 1, and AVL. So this is how we name it. ST elevation, we're going to say acute, and it's going to be a STEMI. And which leads is it? So it's acute, anterior, lateral, STEMI. just to show you pericarditis. This is diffuse ST elevation. You can see here, this person's got elevation at 1, 2, 3, F, V2 through V6. If this was a blockage in blood vessels, the person should be dead because all of their blood vessels are blocked. Going on with that ST elevation, there's going to be PR depression pretty much everywhere except for AVR, where you'll see PR elevation. Sometimes pericarditis can be localized and it'll be only in one area of the heart, and you usually have to do some testing like echo or cath to figure out if they have a blockage in those areas. Just to show you persistent ST elevation. So let's say this person's got an old infarct here. You can see they have Q waves and 3 and F here, but they still have elevation here in this leads. This person actually had an aneurysm in the inferior wall. So again, here's an anterior septal aneurysm. You can see they have Q waves. So this is an old infarct. And they still got ST elevation. This person had a 1 centimeter aneurysm down in their anterior LV. So some more ST stuff. Here's that J point or J wave, or I'm sorry, I shouldn't say J point, J wave early repolarization. Usually what we see is some notching as the QRS comes down to meet that ST segment. And you can see the notch here, you can see the notch here. And then it has this slight concave upward finding here. This is seen in about 1 in 10,000 people. It's generally benign, but about 1 in 10,000 of those 1 in 10,000 have sudden cardiac death. So you keep an eye on these people, but they don't need a defibrillator until they actually pass out or have sudden cardiac death. Here's a slide from Dr. Freeman on how you tell these things apart, and I'll let you digest that later because I understand this is being recorded. Just to show you some other J-wave stuff, this is hypothermia. Here's a person who was found down in Rochester. They went to go check their mail and they never came back, and they were found by his, he was found by his spouse. And you can see here, here's that Osborne wave where we have this funny J-point J-wave elevation. And you can see this person is shivering as all get out on his ECG. Here's Brugada syndrome. So we have J-point elevation that's at least 2 millimeters. And you can see this really funny right bundle branch block, but we call this atypical right bundle branch block with J-point elevation in the literature. And then we get this kind of like ski slope. This would be like a blue, maybe black diamond level ski slope. And what is the tip off between right bundle branch block and Brugada is the S wave is not going to match the size of this R prime. And so that tells you this is going to be most likely Brugada syndrome. So we talked about elevations. Let's talk about depressions. Here's ST depression, where you can see here the ST segment is below that PJ junction or TP segment. And which leads are depressed here? It's V2, V3, V4. So this would be anterior ST depression. So here again, ST is depressed. Where is it depressed? It's below this isoelectric line in V3, V4, V5, V6, 1 in AVL. So this would be anterior based on our roadmap and lateral. So this is anterolateral ST depression. Here's ST depression from digoxin. You get kind of the sagging ST depression, and there's not really LVH here. Some people equate this to Salvador Dali's mustache, and just put a picture here like this. I could never grow facial hair like this, and I have tried. But this is the comparison that is usually made with digoxin. Digoxin does have some other funny rhythms, usually paroxysmal atrial tachycardia. You can get bidirectional VT and amongst other things like that. But for normal rhythm, this is the tip off. They're on a big dose of digoxin. So here's ST depression from left ventricular hypertrophy. We can see here this person has a really big S wave, and then you add it to this R wave in AVL. And whether this is a guy or a gal, it's over these cutoffs. So they have LVH. And with that LVH, they have this sagging ST depression here. So this is LVH with secondary ST depression is usually how it's coded. Here's a table just to show you some ST segment and T wave things. I'm hoping that you started out as this person on the left with the scribbles and we're organizing that like this. And I'm hoping you didn't start over here and now I'm making it like this person over here, squiggly on the left. All right, this is in a Lilly pathophysiology of heart disease books we give to the medical students. It's a really great resource from all sorts of cardiac pathophysiology. It's about just 100 or 200 pages. All right, let's talk about the T wave. The T wave is ventricular repolarization, and the nice thing is it's usually in the same direction of the QRS. So it's positive pretty much in all of the leads except AVR, where it's typically negative. So again, it's ventricular repolarization. It's usually of lower amplitude than the QRS. In young people, you may get inversion in V1 through V3 in these healthy adults. We call this juvenile T wave. You can also see funny inversions if a person paces a lot from their pacemaker and then they stop pacing, they get something called T wave memory. Here are some different waveforms. Here's upright, where it's going up along with the QRS. Peaked is usually as tall as or taller than the QRS. Here's inverted, where it's going opposite of this predominantly positive QRS. Here's notched. What's the difference between notched and like a U wave? With the notch T wave, this notch does not come down to this isoelectric line. So that's usually what we say is notch. Biphasic means there's both a negative and a positive component to it, or a positive and negative component. So just to show you, here's peak T waves. You can see here's our QRS, and the T wave is taller than the QRS. This is the number cutoff, but visually it makes more sense to say, is it as tall as or taller than the QRS? Let's talk about the QT interval. So this is the time from the ventricle activating to the end of repolarization. So it's from the onset of the T wave to the end of the T wave. We don't include a U wave if it's there. Here's an article I wrote about 3 years ago, and with Mike Ackerman, who uses the technique, we teach the tangent as it's called. So we draw a slope along the greatest slope of the T wave, and we see where it intersects this isoelectric line. So even though the T wave ended over here, the QT interval is here where this tangent of the T wave would have intersected at its steepest slope onto this isoelectric line. So this is actually the QT interval. This is the biggest problem with automated ECG reading machines, is they typically miss it when the T wave does this sort of gentle slope onto the isoelectric line. So what do we use for the cutoff? We use corrected QTC. There's all sorts of QTC algorithms, but the most popular one is the Bazette. And when we calculate it, we give 470 for men, 480 for women. Just to show you how we do it, we draw that TP line and we draw the slope along the T wave, and we basically say that the intersection between those two is the end of that QTC here. And then we plug it into this calculation to get QTC. So interestingly, the RR interval is using seconds, so it's square roots of a second, but we use the QT in milliseconds. So there's two different units, and somehow we still end up with milliseconds over here. All right, what are U waves? These are separated from the T wave. They're usually seen in leads V2 and V3, and it's common with left ventricular hypertrophy and hypokalemia. All right, we're gonna totally change gears here for the last 10 minutes and talk about rhythm. So here's one way we do it. We say, is the rate over 100? If yes, we're gonna look at this tachycardia algorithm. If it's no and under 100, which is our arbitrary line in the sand, we're going to say, are there P waves for every QRS, or are there more P waves per QRS? And then if there's no P waves, we're going to end up with AFib and junctional rhythm, which we saw earlier. So let's do the tachycardia part of this algorithm over here. Now with tachycardia, we're gonna break it into, is the QRS over 120 milliseconds or wide, or is it narrow? And then we're gonna see, is it irregular or regular? And if it's irregular, it's gonna be those 3 ECGs I showed you earlier, AFib, aflutter, and multifocal atrial tachycardia. And then if it's regular, we're gonna look at this RP interval, which I will show you. All right, let's first do irregular rhythms. Oop, all right. Oh, sorry. I thought that, so I deleted it because we had too many slides. But here, this would be the 3 slides we saw earlier. So let's go to long RP tachycardia here. So when people say they have a supraventricular tachycardia, we like to speak the language of cardiologists. So the very first thing someone should ask you, is it a long RP or short RP? Well, how do we make this determination? Well, what we do is we look at one RR interval, which is 2 QRSs, and we say the first one is R1, second one is R2, and we ask ourselves, is this P wave between these 2 things closer to the first QRS or the second QRS? And if it's closer to the second QRS or R2, then this is long R to P here, interval. Now, if the P wave is closer to the first R out of an RR interval, this is going to be short R to P, as you can see, short R to P, and we call that short RP supraventricular tachycardia. Some people just draw this imaginary line halfway through this RR interval, and they say, was it on the left side or the right side? And it's on the left side, it's short RP. It's on this right side of that imaginary 50-50 line, it's long RP. So here's sinus tachycardia. So this is a narrow complex supraventricular tachycardia, but we can see there's P waves and they're upright in 1, 2, and F. So if the sinus node is firing, it's going right to left, top to bottom, and heart rate's over 100 because it's under 3 boxes. So this is sinus tachycardia. Here is an atrial tachycardia. And you can see here between these 2 R's, the P wave is closer to the second R. So this is long R to P supraventricular tachycardia. If you look at this P wave, it doesn't look like a sinus P wave. It's not upright in 1, 2, or F. This is actually a spot coming close to the coronary sinus. Here's the junctional rhythm. So there's no discernible P wave, or the P wave is within 60 milliseconds of the QRS. And this is another cause of narrow complex tachycardia. And because this P wave is closer to the second of these R to R intervals, this would be a long R to P supraventricular tachycardia. Junctional tachycardia does show up as a long RP, as well as a short RP, as well as a no P wave supraventricular tachycardia. It's basically all over the differential there. You can see here in this person, they actually have a P wave that's at the very end of the QRS. So this would actually be a short RP. And then here, when you see it convert, that positive deflection actually disappears from here, right? So this is junctional tachycardia as well. All right, let's talk about short RP supraventricular tachycardia. So again, we have a QRS that is narrow. It's less than 120 milliseconds. And in this R to R interval between R1 and R2, there's a P wave that's actually closer to this first R. And for this one, we actually call this a pseudo S prime because it's making this funny S deflection on the end of the QRS. And there's this funny R. And just to show you what this looks like for this person, here's the person, they were in something we call AV nodal reentrant tachycardia. And this P wave is from the activation of the AV node going to the ventricle and going to the atrium at the same time. And this R to P interval is less than 70 milliseconds. When you look at normal rhythm, when this person came out of it, you see this positive deflection in V1, it's gone. And then you see this funny negative pseudo S prime here, the S is gone. And you can see this S prime is also gone in Phi5, if you compare it. And so this person, because this S wave is so close to this QRS, it's AV-NRT. And the reason is something from parallel activation. The atrium and ventricle are being activated at the same time. Here's orthodromic AVRT, or an accessory pathway. So here we have a QRS. It's still narrow. It's less than 120 milliseconds. And if we look between two RR intervals, this P wave is not the T wave. How do we know this isn't the T wave? Well, because the T wave is right here. So from this QRS to this T wave should take the same amount of time. And if you look, translate it over here, here's a QRS, and that would make this second deflection the T wave and not the P wave. Well, in front of it, there's this funny little negative deflection, and this is occurring during part of the heart's activation where nothing's supposed to be happening. This is during phase 2 of an action potential of the heart. This is what we call the calcium shoulder. And if you see a funny deflection here, that's from something else, usually atrial. And that doesn't fit in with a normal SC segment, which is usually going to be flat, horizontal, or another way to say it, upsloping or downsloping. So let's look at this person between when they're in the rhythm versus when they're in normal rhythm. If we look here, here's this P wave and here's this T wave. And when they're in no rhythm, you can see here, there's no P wave. The other thing is, from the onset of the QRS to that P wave is going to be more than 70 milliseconds. And why is that? Well, if we go back to the schematic, during an accessory pathway, we're going to go down this AV node. We're going to generate a QRS here when we get to the bottom. And when we go up the accessory pathway, we're going to generate a P wave. So there's going to be a delay as we go muscle to muscle conduction before we get this P wave. So the time from the QRS to P wave is going to be much longer than if we look at AV-NRT, where it's spinning around the AV node, and we're going to activate the ventricle at the same time we're activating the atrium, or parallel activation. So because this is being simultaneously activated in the ventricle and atrium, these two things are smushed together for the QRS and P wave. Whereas for AVRT, we're activating the ventricle, we get a delay, and then we activate the atrium. And that pushes out this R to P interval. All right, so other things that could happen, you can have sinus tachycardia, but the AV node doesn't work so great. So you get first degree AV block. And that first degree AV block can actually push the P wave closer to the first R in an R1 and R2 interval. And this is all just benign, but it does happen, not infrequently. And so this would make this a short R to P interval. Again, here's junctional rhythm. Here's P wave, it's closer to the first R. Junctional rhythms all over the differential. All right, let's go to wide complex tachycardia with our last few minutes here. So if you see wide complex tachycardia and you say it's VT, you're going to be right 80% of the time. If you just add in this one step, you say, has the person had a heart attack and they have wide complex tachycardia, you're going to be right. It's 98% of the time they're in VT. You can have narrow complex VT. That happens in 4% of VT. You can also have wide complex QRS with supraventricular tachycardia. That happens 7% of the time. What's the differential? So with the differential, if it's not VT, you can get supraventricular tachycardia, pretty much any of them with right bundle or left bundle plus or minus a fascicle block. You can get antidromic AVRT. This is where the accessory pathway is taking the electricity to the ventricles, and then it comes up the AV node. You can get drug effect. Usually this is class 1 antiarrhythmics, particularly 1C agents like flecainide and propafenone. You can get ventricular pacing and artifact. If you do see the QRSs are irregular, always think about atrial fibrillation, and then don't rule out, forget to rule out VT or VF. So let's look at some examples. So here's our northwest axis or right superior axis. This person also has negative concordance. This is VT every day of the week. And this is probably coming from this person's apex. Here, if you only saw the right side of the ECG, you'd be like, yeah, that's wide complex tachycardia. But this person actually has right bundle branch block that you can see here. And when they're in sinus rhythm at the front of it, you can see that the QRS looks exactly the same as when they're in supraventricular tachycardia. So this is just SVT with right bundle branch block here. Here's an ECG that you should know if you cover the emergency department. So this obviously looks like a really bad ventricular tachycardia, but it's actually not. It's actually atrial fibrillation with pre-excitation. And what's the tip off here? You got to remember, when you have an accessory pathway, a ventricle is being activated both through the accessory pathway and the AV node, so you can get some widening and some narrowing of the QRS. And when you get more activation through the accessory pathway, it's going to be wider. And when it's through more of the AV node, it's going to be narrower. And the tip off here is these RR intervals are all over the place. It's irregularly irregular. And so this is actually AFib. Don't give this person adenosine, give them procainamide or shock them if they're hemodynamically unstable. Here's ventricular pacing. You can see here's the ventricular spike, which is digitally inserted by the ECG machine. Here's a patient of mine who took 32 tablets of flecainide in 4 days. He ended up getting an AFib ablation because the flecainide wasn't doing the job. But you can see here that 1C agent really widened his QRS. Here's hyperkalemia. This is a person who missed a whole week of dialysis. And you can see these really peak T waves. The QRS is really quite wide. They've lost their large portion of their P wave. Their potassium was 9.5 here. Here's artifact. This person was shaving. And you can see the QRS are marching out here, but that shaver is making all this noise, and people rushed in to find the dude shaving to go home. So, all right, let's talk about what happens when we have no tachycardia and we have that 1-to-1 P wave ratio. Here's our differential, and then any of these also with first degree AV block. So again, we saw sinus rhythm. We won't cover that. Here's ectopic atrial rhythm, again, non-sinus focus. Here's the opposite of multifocal atrial tachycardia. It's basically 3 separate P wave morphologies, but the rate is under 100. And you can see here, I color-coded the different P waves just to show you where they're coming from here. This is usually benign. We don't need to do anything for it. All right, what happens if we have more P waves than QRSs? Here's our list. Here's that Wenckebach ECG we saw earlier. So the one that has a very similar name is second degree AV block Mobitz type 2. And if we go back to this Wenckebach, we had that progressive PR prolongation before the P wave dropped. And then the P wave to QRS or PR interval shortened again. But with Mobitz type 2, you don't see any shortening of the QRS or when it resumes conduction, and we don't see any lengthening of the PR interval before it drops. So you can see here, this PR interval is pretty consistent, and then we just have abrupt loss of conduction. This is dangerous because this suggests the block is below the AV node, and that makes it unreliable because there's not what we call automaticity, where the electrical system will spontaneously fire unless it's really diseased. So only the sinus node and AV node have that automaticity from phase 4 spontaneous depolarization. The next level would be 2-to-1 block. This is where there's 2 P waves for every QRS. This very well could be Wenckebach, where instead of 4-to-3 or 3-to-2, we're seeing 2-to-1. If you were to see another ECG or telemetry that showed Wenckebach, this would most likely be Wenckebach as well. But this could also be Mobitz type 2, where it's just abruptly dropping. This person needs further evaluation and testing. Here's high-grade AV block. This is where the P waves are marching out, and intermittently, they're able to affect the QRS. So you look here at these QRSs, they're a little bit irregular, and that's because intermittently, this P wave is able to affect this QRS, as you can see here by these orange bars. All right, so we give this its own name. It's called high degree AV block. Whereas if there's no relationship between the P waves and the QRS, and the P waves are going at their own rate, the ventricle is going at its own rate, we call that complete heart block. Just to wrap up the last 2 things, This is premature atrial complexes. So let's say we have the P waves occurring at a regular interval here. But what happens is the atrium has an extra spot that fires early. This P wave catches the AV node when it's not able to conduct. And this is also able to usually get into the sinus node and create this pause. This PAC, it's benign, but it is the most common cause of pauses on telemetry. And usually we don't need to do anything about it unless the pause is more than 3 seconds here. Same thing here. Here's a ventricular activation. And then this PVC occurs earlier than expected. And this can also cause pauses by it conducting into the AV node. This person has a right ventricular outflow tract PVC. Those are the most common PVC we see actually. Oh, and asystole. So obviously there's a lot of little squiggles being P waves and not enough big squiggles being the QRSs. This is obviously a bad situation. And that's it. All right. Thank you for inviting me.
Thank you so much. How did you get them on the, oh, you just like, that's cute, on the car. Dan, you always do such a great job making complicated topics easy to understand. So thank you for joining us. We're kind of running a little bit behind, but I think we will have probably a shorter Q&A session. We will welcome back Kristen Babb, who is also going to be speaking about EP. She's going to present an interesting case. She's a physician assistant working at Banner University Medical Center. Let's try again. We had technical difficulties last time around.
Yeah, thanks for having me back. So Leanna and I tried to do a quick way to see if I could get this to share, and I'm getting the same error, which is strange. Cecilia, I think you have my slides. Could you pull them up?
Yes, I'll try to do it now.
I always think I'm so technically logically advanced, and my, kids kindly remind me that, I'm very challenged.
Looks great.
All right. So is that, Cecilia, will you advance them for me then?
Sure.
Okay, great. Well, again, I'm Kristen Babb. Thank you so much for having me here today. Really honored to be here. I am part of the EP team at Banner University here in Phoenix. And today I'll be talking about an interesting case in EP of long QT syndrome. Here are my disclosures. I'm a consultant for Zoll Medical. And the case today was a 20-year-old female that presented from a local cardiologist for EP evaluation for ICD. This is actually a patient of Wilbur Sue. She came in with a history of recurrent syncope during childhood, particularly during PE class, and then a near drowning at the age of 12. She did have a confirmed diagnosis of long QT syndrome 1 by genetic testing, and then anxiety. She was on appropriate medical therapy for the long QT with beta blocker Nadolol, and then sertraline for her anxiety. Her vitals were very stable on her initial evaluation. Next, her family history, she actually had a brother with sudden cardiac arrest at a very young age. He had a defibrillator and had a confirmed diagnosis of long QT1. So he was the proband, meaning he was the initial person in the family who had the diagnosis. But back to our patient, she had testing, including an echo, which was essentially normal, and then exercise stress testing showing a prolonged QT with exercise, which is defined as greater than 480 milliseconds. And, just a reminder that prolonged QT with exercise is pathologic. You would expect the QT to shorten with exercise. Here is her presenting EKG, and great presentation by our last presenter at measuring the QT interval. So I'm looking particularly here at lead 2 and lead 5, trying to get a sense of what her QT is, really measured out to be, I believe, Cecilia, if you want to hit the next, actually go back. I believe it was about 450. And then if you correct it for her heart rate of 72, it gives us a QTC of 492 milliseconds. So this got me thinking, what if we didn't have her genetic testing results? How would we make this diagnosis if we weren't so lucky to kind of have the slam dunk of the genetic testing results already being available to us? Certainly, I've been in practice for 15 years and practiced at the time when we really didn't have this, or it was so expensive and not approved by the insurance. So that gets us to the next slide where we talk about the Schwartz score. And this is an older score, but still very much in place of how do we decide what's the probability that this is a true long QT syndrome? It's really based on 3 categories. So the first one is EKG findings, second is clinical history, and third is family history. So with our particular patients, we're looking at a resting QT of 492 milliseconds, which would give her 3 points on the Schwartz score. She also did already have a stress test showing prolonged QT with exercise, which gives her an additional point. She did not have torsades or T-wave alternance testing. She doesn't have a notch T-wave in 3 leads and didn't technically have a low heart rate for age. The low heart rate for age is defined as 2% or less in the percentile for the age. For her, would have been 52 beats a minute. And I looked back at all of her vitals, which were more in that 70 to 80 range. Then the clinical history, which is the most important when we're evaluating patients for long QT. I can't stress enough how much, how important this is, and really just sit down and take a detailed history. So for her, we found that she had 3 syncopal episodes in elementary school, all associated with PE class. Then she also had a near drowning at the age of 12, which is a huge red flag. We should always be aware of that, that a near drowning and her or a family member needs to be congenital driven arrhythmia unless proven otherwise. So she gets an additional 2 points for that. And then her family history with a brother with definitive long QT syndrome, she gets an additional point. So her score equals to 7, which is double the high probability of long QT. We do the next slide, please.
It's not advancing. Okay.
All right. So then we look to the expert guidelines. And what do we have available to us to help us with our diagnosis and our treatment? And although there hasn't been anything super recent, in 2013, there was an expert consensus statement that recommended a diagnosis of long QT when any of these 3 criteria were met. So the first one focuses on the Schwartz score of at least 3.5. And of course, in the absence of any secondary cause of QT prolongation, QT prolonging drugs, or of course, electrolyte abnormalities. Second would be a confirmed diagnosis of a gene mutation. And then the third criteria would be a QTC of at least 500 in repeated EKGs, again, without a secondary cause. So thinking back to our particular patient here, she actually meets all 3 of these, or closely. I guess the third one, her QT was 492. So she at least meets 2 of the 3 of these. So then what are the recommendations? Class 1 recommendations would be avoidance of QT prolonging drugs. It used to be called qtdrugs.org. Now we really use crediblemeds.org. And this is so important to have on your phone and really have available to the patient as well, to make sure that they avoid any drugs or supplements that would potentially prolong their QT even further. I always counsel the patients to do a timeout. If they're seeing their primary care or another physician and a medication is being recommended, really just telling them to do the sign, the timeout, I have prolonged QT, how will this affect? And really raise those flags to every provider that's caring for them. And then, of course, identification and correction of any electrolyte abnormalities, especially when these patients are sick, and try to counsel them over and over again that this is so important if they're sick and they need to be well hydrated and replacing their electrolytes. The next class 1 recommendation or beta blockers are recommended in patients who are asymptomatic with a QTC greater than 470, or those with a history of syncope or documented arrhythmia. The next thing we talk about here is left cardiac sympathetic denervation. And this is really recommended in patients that ICD therapy is contraindicated or refused, or beta blocker is not effective in preventing symptoms or recurrent syncope. This isn't something I've seen a lot in clinical practice, but just to kind of review that left cardiac sympathetic denervation is the removal of the sympathetic chain and paravertebral ganglia to prevent the norepi release to the heart to decrease the risk of arrhythmias, and certainly can be used in this type of patients. ICD implant can be recommended in patients with long QT who are survivors of cardiac arrest. And that gets us back to our patient here with a near drowning incident in the past. I think we could appropriately call her a survivor of cardiac arrest. And then any patient with long QT syndrome who wants to engage in competitive sports should really be sent to a long QT expert or EP for further evaluation of risk. Class 2 recommendations, you can consider beta blocker in patients who are asymptomatic with a QT less than 470. And another two-way recommendation is that ICD implant can be useful in patients who have recurrent syncope, especially when they're already on beta blocker therapy. Again, you can consider sympathetic denervation in patients who have breakthrough events while on beta blocker therapy. Especially keep this in mind in patients who already have defibrillators and are having recurrent ventricular arrhythmias leading to appropriate shocks. Certainly, we've all seen it in patients with appropriate shocks and the PTSD that can cause them, and the lifestyle limitations that gives them moving forward. And I apologize, these slides are a little off, I think, just because of the format, but you can also consider other antiarrhythmics if you have patients who continue to have symptoms, in particular sodium channel blockers. And then the class 3 recommendation really just points out that except under special circumstances, ICD is probably not appropriate in asymptomatic patients who have not been tried on beta blocker therapy. So the next slide talks about the ACC guideline recommendations, which I won't spend too much time on since we just went through the expert consensus statement, and there's a lot of overlap there. But just a few things I'd like to point out is the class 1 indication to make sure that patients who are diagnosed with long QT syndrome, that they are referred for genetic counseling and testing. This is very important for them and their family members in particular. And then really the only other difference here is the class 3, just pointing out that QT prolongations are harmful, which is fairly obvious, but always something to keep in mind. So let's talk a little bit about EKG patterns and LQTS. So really 3 major types, 1, 2, and 3. And although we already know, we kind of had a slam dunk that this patient was referred with a known diagnosis and confirmed by genetic testing of long QT1. But the EKG pattern tends to be fairly normal proportions there. Where in long QT2, you'll see more of that notch T wave, or they call it bifid T wave, that's low amplitude. And then in long QT3, you'll see that long ST segment that tends to be isoelectric. And then what about symptoms? How do these patients vary? How do they present? And again, very consistent with our history in this 20-year-old patient. Long QT1 often occurs with exercise. So whenever their heart rate's elevated, sometimes you mainly will be under physical stress, but I have seen the emotional stress as well. They'll tend to have syncope or near syncope. Long QT2 is often when they are startled. You may have heard the classic example of that would be a new mother and baby starts crying in the middle of the night, suddenly wakes her and she becomes symptomatic or has a syncopal event. And then with long QT3, it'll often occur with sleep or more bradycardia induced. So which beta blocker do we use, and does it matter? And for those of you that were at HRS this year, there was a hot topic about this. But I think the majority of the data suggests that propanolol or nadolol are really the most appropriate beta blocker choices in this patient. I'm not sure my animations are working with Cecilia doing my slideshow, but just keep in mind those propanolol and nadolol are most appropriate. So what did we do with this patient? She met the criteria for ICD implant. Certainly think she will benefit from it. And she's young and she really doesn't have an indication for pacing. She's not bradycardic. And so we ended up doing a subcutaneous ICD. She underwent the implant without complication and is currently doing really well. I would continue to up titrate her beta blocker as she can tolerate. She hasn't had titration in really about a year, and she really seems to tolerate it well. And so I think we'll continue to do that, especially if she continues to experience symptoms. And then if unfortunately she's having recurrent arrhythmia or appropriate shocks for VT, I would consider again the sympathetic denervation. So then she tells me at follow-up that she may consider getting pregnant. So I got to thinking, well, gosh, what's the probability that her child will have the same long QT syndrome? And again, I think the animations aren't working right now, but what it is 50%. It's an autosomal dominant and it affects males and females equally. So the probability would be about 50%. That's all I have for you guys today. Again, it's an honor to present to you. I had to end with a picture of us recently at Rocky Point. There's my daughter, Olivia, and my little crazy dog, Archie. And thank you so much.
I think you're on mute, Cecilia.
Oh, thank you, Kristen, for a great presentation on long QT syndrome. In the interest of time, as we are running really late, we will just try to shorten our Q&A. I do believe there's only 1 or 2 questions on the Q&A right now. And the question is, if you want to re-listen to this Zoom again and print pictures out, how do we go about it? So the video recording will be available on Monday at the ACC website for Arizona. And then in terms of printing, maybe we can ask the speakers to share their slides, to share with our attendees, if that's possible.
I think from the video as well, I mean, you could probably just pause and Control-Shift copy the slides that you find most relevant. That would be a way to do it too.
Okay. Right.
But
or
yeah,
take a picture.
If we could take PDFs, that would be great. Maybe on the website, both have PDFs of the lectures as well as the video.
I think that's any other questions out there?
I had a quick questions for the fantastic cardiac rehab talk crew. In the pandemic, have we been able to develop and successfully conduct cardiac rehab through telehealth tools?
Yes, in some cardiac rehabs, they have gone to virtual. There's certain criteria that they need to meet in order to get reimbursed, and that's the sticky wicket. But we either at Mayo Clinic, we actually did a phone app and were able to give the patient feedback because we could see what they were doing at home, and that was through phone calls. But there is a process to do it virtually, and it's kind of a work in progress.
Have you found it to be as effective or less effective with the patients who have chosen to engage with the virtual option?
There has been a study done that said it was as effective. I think the personal touch and the ability to connect with the patient a little bit more one-on-one is irreplaceable. But as we move forward in technology and the virtual rehab, I think it's going to be the way of the future.
Any more questions from the Q&A? You said there were two. I think we answered one.
I think there's only one.
Okay, there's only one.
Taken, sorry.
Well, I suppose, thank you, everyone. That was a fantastic round of talks. Covered such a nice, clinically relevant subset of topics. For Dance, Raja, hey, applause. Applause for everybody too. I suppose we'll see everybody back in 10 minutes. Wow.
Yes. We'll take a short break and we'll be back on time at 12:30.
Also been a legislative chair at the Arizona chapter for ACC. Welcome Heather, who's going to be speaking on the topic policy for cardiovascular team, how to make a difference.
Unfortunately, Dr. Heather Ross couldn't join us on Zoom meetings, but she's kind enough to pre-record her talk this afternoon.
Hello, everyone. I'm Dr. Heather Ross. I'm so happy to be here by video with you today for the Arizona ACC Cardiovascular Team Symposium. I am by profession a nurse practitioner. I've practiced in the field of cardiac electrophysiology for over 20 years. And I'm also for the American College of Cardiology nationally. I chair the CV team or cardiovascular teams advocacy committee at the federal level or the national level with the American College of Cardiology. And also for the past few years, I've had the opportunity to contribute to the Arizona chapter of the American College of Cardiology, leading some of our advocacy efforts here in the state of Arizona. So I'm so grateful for the opportunity to talk with you today about policy for the Arizona ACC cardiovascular team. So thank you for being here. And let's talk about what's new this year as I record this towards the end of 2021, and you're going to be viewing it just a couple of days later. What's new and how to make a difference, because that's, of course, why I hope that we're all here together, is not just to learn a couple of things, not just to get some new information, but what to do with that information and take it forward. And hopefully we'll be able to give you some tools that you can use to act. So what's new in policy? Boy, it's been a couple of really interesting years for us in healthcare here in the United States and globally. So here are some of the things that have been going on in 2021. So telehealth, I think that every one of us has probably been touched by telehealth, either in our practice or in our personal experience as patients. We know that telehealth services were expanded in 2020, and they were extended at the end of 2020 relative to the pandemic. To continue that expanded offering of telehealth services so that we could reach more patients for more types of telehealth services. And your American College of Cardiology has engaged in extensive legislative advocacy in 2021 to make those extensions permanent. Now, there are a couple of different bills out there. One that's getting a lot of attention is the Connect Act, and that's gotten a lot of sign-on from House members. And there's also the Telehealth Modernization Act. That's the one that the ACC supported, and I have some exciting news about that I'll share in just a moment, and that's kind of hot off the presses news. Before we get there, I wanted to share with you that in 2021, we have some movement with some of our colleagues in the space of advanced practice. So we have a lot of naming issues at stake with regard to advanced practice clinicians, which, by the way, is the way that the advanced practice community is coming together to have sort of a group naming convention. There's a lot of different professions that go into advanced practice, and we're going to talk about some of those new names in a moment. But before we get there, I will tell you that in 2021, advanced practice clinicians, by virtue of some of the expanses or extensions as a result of the pandemic, advanced practice clinicians can supervise now an expanded list of procedures. So it used to be that there were a lot of procedures that advanced practice clinicians could perform, but couldn't supervise another member of the cardiovascular team, for example, a registered nurse or a cardiovascular technician. Well, that has changed, and advanced practice clinicians now can supervise an expanded list of things, for example, stress tests. So that was a really important advancement that came as a result of the pandemic. Very much affects us in the policy space. Cardiac rehab supervision by advanced practice clinicians, including nurse practitioners, PAs, and clinical nurse specialists or CNSs. It's still coming. In 2026, you may remember that in 2018, the ACC was able to get that supervision issue included in the Omnibus Budget Bill and Act of 2018, but it's not going to be enacted quite yet. So we're trying to get that enacted sooner in 2022 now. The reason that it was put off for so long had to do with balancing the budget and some tricky math that happens sometimes in the United States Congress. So we're working on getting that instantiated sooner, because we know that now more than ever, our patients have just a heck of a time getting access to rehab services because they are few and far between, particularly in rural areas. So we're hoping to be able to expand access to cardiac rehab services, which benefits really every part of cardiovascular care on down the line, not the least of which are patients, because we know obviously so well that cardiac rehab benefits our patients in the short and long term. Now we have some new names. I mentioned of our cardiovascular team, we have our advanced practice clinicians and two new names that our advanced practice clinician professions have begun to use here in 2021. So the first to highlight is our previously known as physician assistants, who in the past few years have gone to preferring the name PA. Well, this year, the PAs have renamed themselves physician associates. So we're really happy to support that name change, that our physician associate colleagues feel really much better reflects the work that they do and the profession that they represent. So we now have the American Association of Physician Associates as the AAPA as one of our key partner professions in the cardiovascular team. I also want to highlight that our nurse anesthetist colleagues have changed the name of their professional organization to now be the American Association of Nursing Anesthesiology. And so really happy to see the advocacy that our colleagues are doing around their profession and the services that they offer, and of course, high quality services across the board. So some additional legislative priorities in 2021 that the American College of Cardiology went to the Hill virtually again this year in 2021, but these were our legislative priorities that we took to the US Congress. And I'm very happy to share with you that we had a really lovely group of mostly cardiovascular team members actually from the state of Arizona that made up our Arizona advocacy team on the Hill this year. Here's what we talked about: protecting patient access to Medicare services by stabilizing the payment system. As you know, or maybe you know, maybe you don't know, but you're about to know, the Medicare and Medicaid payment system right now is tied to the federal budget and how Medicare is doing financially in the federal coffers. And one of the things that has come to pass is that we have had Medicare reimbursements continue to drop in an effort to cut costs and balance budgets. And it really has massive potential impacts on the healthcare services delivery. So we were advocating for protecting that patient access to Medicare by stabilizing the payment system. Now in the House, we had more than 100 US representatives sign on to what we call the Barabouchon letter. Super important and really wonderful participation from our congressional delegations across all 50 states. And we're looking for similar letter-based activity in the United States Senate. We also talked about decreasing administrative burden through the Improving Seniors Timely Access to Care Act. We also talked about increasing patient access to care and improving cardiovascular services through the advanced practice clinician supervision of cardiac rehab, like I just mentioned a moment ago, and also the Cardiovascular Advances in Research and Opportunities Legacy, or CAROL Act, which was introduced as bipartisan legislation in both the House and the Senate, has to do a lot with population level research around valvular heart disease. And I'm very pleased to tell you two things. One, the reason that it was able to be introduced as bipartisan legislation in the United States Senate is because of the work that ACC cardiovascular team members have been doing with Senator Sinema's office for many, many years. And so she was the original co-sponsor of this cardiac research bill in the United States Senate. So go Arizona CV team. The other thing I'm really happy to tell you is that just this week, the CAROL Act passed the House. So that was really exciting. And we hope to see this continue to move forward in the Senate. And then finally, protecting access to telehealth services. Now, one thing about that, as I mentioned, that the ACC very specifically supported the Telehealth Modernization Act because it was going to expand telehealth services in a much more comprehensive way, including the cardiovascular team in a much more comprehensive way. And just this week, hot off the presses, happy to tell you that Representatives DeGette from Colorado and Upton from Michigan introduced the Cures 2.0 bill in the United States House of Representatives. And in that bill, there are several things that impact the cardiovascular team. One of those things is that the Telehealth Modernization Act was included in that Cures 2.0 bill. So we're very optimistic about that. Other things that were included in that Cures 2.0 bill include Medicare coverage for pharmacogenetic consultations, which really directly impacts our PharmD cardiovascular team members, and also educational programs and training for caregivers, so lay caregivers, family members, loved ones, to learn the skills that will allow them to augment the clinical work of the cardiovascular team. Now, not just specifically to cardiology, but all care teams, but certainly that's a place that us as the cardiovascular team, our world touches. So super excited about the Cures 2.0 Act. And like I said, this is hot off the presses, literally happened yesterday from when I'm recording this talk for you. So, okay, I told you a lot of information about what's been new in 2021, now how to make a difference. So one of the things that I hear a lot when I talk to my students in my day job as a professor at Arizona State University, I hear people say, I didn't go into nursing or I didn't go into cardiology to do politics. But here's what I have to tell you, that there's a Venn diagram between policy and politics, and where they overlap, that's where the action happens. That's where the work gets done. So engaging in policy doesn't mean that all policy is politics, but there is a lot of overlap there. So it's important to be aware of it and to then engage with politicians and our elected officials. So you may say, I'm a policy novice. How on earth do I get started with this? Well, there's a bunch of things that the ACC has to offer you. One is in a lot of states, state lobby days. Now, we haven't had a state lobby day from the Arizona chapter of the ACC yet, but a lot of states do. And here in Arizona, I know that a lot of our representative professions, for example, the Arizona Nurses Association absolutely has lobby days, and I encourage you to participate in those with your profession. We also have micro-volunteering available at the national level at ACC. You can get more information about that from our ACC representatives, or I would suggest Celia can give more information about that as our cardiovascular team representative or liaison to the ACC Board of Governors. We also have the ACC Legislative Conference, which happens in Washington, D.C. The last couple of years it's been virtual, but normally in Washington, D.C., it usually happens in October. And here is the link on the acc.org website. And you can, of course, use the search bar to get information about the legislative conference, but learn a little bit more there. While you're on the ACC's website, I encourage you to check out the ACC Advocacy Actions section, which is a lot of what allows you to engage in like armchair advocacy, where you can send quick emails to your federal representatives, really useful tools that I encourage you to take a look at. And then also, I do encourage you to check out the Heart PAC, the Political Action Committee of the ACC, and really encourage you to participate, because here's the deal. Advocacy takes money to get it done, to do the work of advocacy, and the Heart PAC is what makes that happen from the ACC. So everything, anything that you contribute to that, please know that it's helping us get really good policy done on behalf of our patients and on behalf of us as the cardiovascular team. So now how to reach policymakers. I gave you the ACC Advocacy Action link, so you can check that out on ACC's website. But what do you do once you have that connection to a lawmaker or that contact information? If you're going to send an email, make it short and sweet. Put your ask or your issue right up front. So do be short, but also be sweet, meaning be kind. Contacting lawmakers by saying, I'm not going to vote for you if you don't do that. Just be kind, be professional, be polite. And same thing if you're going to contact them by phone. If you're going to contact them by phone, you're most often going to be talking to a staffer, and it's worth being succinct with your message and also being kind, and of course thanking them for their time. If you're going to engage in person, and I encourage you to do that, I encourage you to do that early, meaning don't wait until legislation's getting ready to be voted on. Meet with lawmakers and with elected officials before the legislative session begins. meet with them often. Don't just meet with them once. Come back and see them every year or every few months. Attend their public events and things like this. And do follow up with email. Doesn't have to be a novel, but a quick email, always thanking them for their time and reminding them that you are available to be a resource for them in the field of cardiology. So now how to find and reach your Arizona policymakers. You can find your state legislators. So everybody has 2 representatives and 1 senator in the state legislature, and you can find them on the legislature's website, azleg.gov/findmylegislator. And you can literally put in your zip code and it'll pop up what legislative district you live in and who your legislators are, and including their office phone number where you can reach their staff member, and also their email. You can email them directly. So that's when you want to make your email short and sweet. You can call them, making your phone call, again, short and sweet. And I do encourage you to attend their community events. Don't forget about your county supervisors that you can also contact by phone or email, and your city council members that you can contact again by phone or email, or attend their community events as well. And then how to make your voice heard in policy here in Arizona. You can do request to speak at the Arizona legislature. More information about that at azleg.gov. At this website that's up here on the screen, AlicePDF/using request to speak program. You do have to create a new account using a kiosk at the Arizona Capitol or in Tucson, and you don't have to actually speak, but you can register your support or opposition to a bill. You can also testify at city council and school board meetings and get more information about that on their specific websites. And that is it. This was the shortest, the quickest, the hopefully most action-packed talk that you're going to have on policy, at least today. Let's set the bar low. But thank you. Thank you for engaging. And now, please go out and talk to your policymakers, because that's how we get our work done at the ACC and in the cardiovascular team, both here at Arizona and also in the United States. Thank you, everybody.
Thank you, Dr. Ross, for sharing your expertise in legislative advocacy. Truly appreciate her help, especially when I first attended the legislative conference in October. I was so nervous and hesitant to speak to their representatives, but between Dr. Quanley and Dr. Heather Ross, we made it through. Now moving on to our next speaker, we're gonna talk about adult congenital heart disease. We have Susie Papp. She is a family nurse practitioner in adult congenital heart clinic or heart disease at the Phoenix Children's Hospital. Her interests are advocating for the congenital heart disease and adult congenital heart disease population through the Adult Congenital Heart Association and caring for patients with congenital heart disease during their pregnancy. Susie, take it away.
Thanks, Cecilia, and thank you everyone for being here. I'm really honored to be asked to speak. This is really a great symposium with fabulous presentations. And I hope that in the next 20 minutes, I'll tell you everything there is to know about adult congenital heart disease, or not. I'll start sharing my screen, and hopefully there won't be too many technical difficulties here. Okay. So just some objectives today. We'll review some of the congenital heart defects, really to understand how the ACHD population has evolved over time, to understand which lesions should be referred to a dedicated ACHD program, and to understand the specific challenges involved in caring for ACHD patients. I have no disclosures. So a little review and some history. CHD is the most common birth defect. Almost 1 in 100 children are born with CHD. And previously many forms of complex CHD were uniformly fatal in childhood. And it really wasn't until the 1970s or 80s when mortality starts to improve. This is when cardiopulmonary bypass really came into modern use. We saw improved surgical techniques and options. So for example, for our single ventricle anatomy and physiology palliations, we started using the Norwood procedure for the first stage, and then the Fontan completion for the final palliation. And then for our patients with transposition, we moved away from the mustard and Senning atrial switch operations to the arterial switch operation. We also saw earlier surgical timing. Originally, people thought that neonates and infant hearts really couldn't tolerate cardiopulmonary bypass. But as we started surgical interventions earlier, we saw that they were really more robust and able to withstand such procedures. This, coupled with improved management and improved diagnostics, really helped us shift the median age of patients with severe CHD to increase from 11 years in 1985 to 25 years in 2020. Today, most children born with CHD are expected to survive to adulthood, which is very different than decades ago. Currently, about 90% of all CHD patients are expected to survive to adulthood, and each year more than 20,000 CHD patients in the US reach adulthood, which brings us to our current state where ACHD patients outnumber pediatric CHD patients 2 to 1. So talk about some job security and job opportunities. This graph really shows us that with these surgical innovations, survival trends changed. And this is a Canadian registry looking at mortality in their CHD population, which are represented by the yellow bars, and how it compared to mortality rates of the Canadian population at large, which is the black line. So whereas in the 1970s and 80s, a large portion of complex congenitals were dying young and none were making it to adulthood, in the early 2000s, survival trends began to move closely, to more closely follow those of the general population. This slide shows similar survival trends, and we see that patients with simple complex CHD really have a pretty normal mortality trend compared to the general population. But this also shows that as complexity increases, so does our mortality, which goes to suggest and support the need for specialized care for our ACHD patients. Research has showed that patients with complex CHD have generally better outcomes when cared for in an integrated, collaborative, and multidisciplinary program. Many medical issues in patients with ACHD involve cardiac sequelae, and the diagnosis and management may require electrophysiologists, interventional cardiologists, advanced imaging services such as cardiac MRI and CT, pulmonary hypertension services with expertise in ACHD, and ACHD in pregnancy. So appropriate specialty care must be available to address common ACHD issues, as such management is frequently more complicated in patients with ACHD. And these include things like pregnancy, acquired cardiovascular disease, and acute non-cardiac illnesses that complicate CHD. The Adult Congenital Heart Association, which is the accrediting body for ACHD comprehensive care centers, have required all of these subspecialists to achieve accreditation as a comprehensive care center to provide appropriate levels of care for our ACHD population. Currently, there are 453 board certified ACHD physicians to take care of about 2 million patients. Again, lots of job opportunity and job security. but greater than 40% of ACHD patients fail to transition and experience significant gaps in care. And this includes a significant portion of patients with moderate and complex disease. And so what we see is that these patients show up to cardiologists who might lack experience, and these patients are often sicker. And as ACHD has become a new subspecialty of medicine, we see that we have growing pains and more needs. And so now we're having to come up with how to coach our pediatric patients on continuing a lifelong of specialized care. And sometimes that often means staying at the pediatric hospital, because many ACHD programs are affiliated or established at our pediatric hospital. So common sense might tell an adult patient that that's the pediatric hospital, I can't go there for care, I'm an adult now. And so we see that some of these things often contribute to why patients get lost to follow up. What diagnoses to refer? Definitely the more complex defects, repaired or unrepaired, and complicating conditions, either cardiac or non-cardiac. It's always best to refer early to avoid potential post-op or natural disease progression consequences. What sorts of congenital heart disease can be followed in an adult cardiology practice? Pretty straightforward or safely. That would be simple native disease, such as isolated and small atrial septal defects or ventricular septal defects, along with mild isolated pulmonary stenosis, and some simple repaired conditions, such as a patent ductus arteriosus that's been ligated, or a repaired secundum ASD or sinus venosus defect without significant residual shunts or chamber enlargement, or a repaired ventricular septal defect without significant residual shunts or chamber enlargement. And these patients should also be a physiologic stage A, so asymptomatic from a heart failure standpoint, without hemodynamic or anatomic sequelae, no arrhythmias. They should have a normal exercise capacity and without evidence of end organ dysfunction. Anything more complicated than this really needs to be seen in an ACHD clinic. So why refer? CHD may be repaired or palliated, but CHD itself is never cured, and lifelong specialized follow-up is essential. We see improved outcomes when patients are followed at ACHA accredited centers. And there are multiple consequences of surgical repairs and natural disease progression, such as arrhythmias, pulmonary hypertension, pregnancy, acquired heart disease, valvular heart disease, aortopathy, and reduced exercise capacity that really require an expert to manage. We have at our accredited centers, or who to refer to, excuse me, would be an ACHA accredited comprehensive care center. Phoenix Children's Hospital is the first and only in the state of Arizona, and the Adult Congenital Heart Association has a list of all of the accredited centers that can be found at their website, achaheart.org. And at these accredited centers, we have teams that are deep in subspecialists with experience and training to care for the special needs of our congenital population. We also are fluent in the congenital language and evaluation and treatment of patients with a congenital approach and following congenital processes. We utilize a special anatomic and physiologic classification system because clinical status and condition depends not only on the complexity of disease, but also the functional status and complicating factors, cardiac and non. And this classification system has prognostic value. So an example of why we use it and why it's important is if we look at a comparison of two patients at the same age with the same CHD diagnosis of tetralogy of Fallot. One may have had a valve-sparing primary repair and now has excellent biventricular function with normal exercise capacity and no arrhythmias, whereas the other may have first had a palliative shunt followed by a transannular patch repair that now has severe pulmonary regurgitation with RV enlargement and biventricular dysfunction and ventricular tachycardia. Here's a map of all of the ACHD accredited centers across the US. Currently, there are 34 programs in 23 states. Unfortunately, this number continues to grow. And at all of these comprehensive care centers, our team is multidisciplinary in nature and consists of an ACHD board certified cardiologist, an advanced practice provider, a nurse, and a social worker. And we work alongside our transition program because oftentimes our ACHD programs are at pediatric institutions and we work collaboratively with our pediatric cardiologists. So it's really important that as our pediatric patients graduate to adulthood, that they transition properly and we avoid that or we are able to provide consistency and continuity of care and avoid a break in their care. That brings us to one of the common ACHD issues that we face, and that's the continuum of responsibility. So as patients grow up and graduate from being a pediatric patient to an adult patient, we really have to help empower them to assume responsibility and take over managing their own care and teach them how to do that. We also have to help parents to let go of some of that and learn to take on a more supportive role and teach them how to do that. It's oftentimes difficult for our parents to kind of let go. We see that as patients transition, there can be a wide spectrum in terms of the knowledge of their disease. Some are very knowledgeable and others are completely in the dark. And oftentimes there's some misunderstandings and misconceptions because we may say we've fixed your heart when we perform a surgical repair, but that doesn't mean that we've cured the congenital heart disease. And so it's really important that these patients properly transition and have a lifelong of specialized care. Actually, 10% of congenital heart disease is diagnosed in adulthood. This can often be things like atrial septal defects, partial anomalous pulmonary venous return, coarctation of the aorta, Ebstein's anomaly, congenitally corrected transposition or LTGA, anomalous coronary arteries, and of course, bicuspid aortic valves. One of the things that we have to evaluate really on a patient-by-patient basis is where is the best care delivered? This is a pediatric problem for all of our ACHD patients, but oftentimes our patients have adult comorbidities. So do we have them come to the pediatric hospital where they've been cared for their entire life? They probably feel safe and at home, or do we have them venture out to the dark and scary adult hospital? And both places have their benefits, but both also have their drawbacks. The pediatric hospital oftentimes have providers with lots of congenital anatomy and physiology knowledge and experience with right ventricular disease and dysfunction, which tends to be more common in the congenital population, but they don't have experience in adult comorbidities and acquired heart disease. Additionally, the physical hospital, pediatric hospital itself may not be equipped to take care of our big kids, if you will. We may not have the appropriate resources to provide care for our adult patients. Additionally, our nursing staff tends to be very pediatric focused. So when caring for an adult patient, that sets us up for things like errors that we really have to speak to and try to be proactive about to prevent. but the pediatric hospitals oftentimes don't have the adult subspecialists for the comorbidities that our patients may have. In comparison, the resources, the specialists, the staff at the adult hospitals are all well equipped to take care of adult problems, but they don't have the experience in congenital issues like our providers do at the pediatric hospital. So for some patients, the pediatric hospital might be the best place for them to receive care. And for other patients, the adult hospital might be the best place for them to receive care. And oftentimes we can bring our congenital specialists to the adult hospitals so that they can kind of have the best of both worlds in some senses. Some of the common issues that we see in our ACHD patients are redo surgeries, valve repairs and replacements, aortopathies can develop. Our patients with single ventricle physiology who have had Fontan completions, that may only be good for so long and they may need a conversion, or as things start to fail, we may need to talk about mechanical circulatory support or transplant, and that's a whole nother world in and of itself. And sometimes we even see incorrect surgeries. Our adult congenital population has a lot of atrial arrhythmias. Heart failure is also a common issue, and not only for our Fontans that we see over time just fail. It makes sense when we only have one ventricle to work with. Sometimes that's a right ventricle that has to do the work of the left. Obviously, that's not something that's going to last the same as a left ventricle in a normal heart. And our Fontan patients, because of the anatomy and physiology in the Fontan circulation, we really have to address them from a multi-organ system approach and have neurodevelopmental and psychology specialists available, hepatologists and nephrologists. Coronary issues also apply to our ACHD population, but there's an assumption that CHD patients are at an increased risk of coronary disease, when in fact we actually see that most ACHD patients presenting to the ED with chest pain rarely have acute coronary syndrome. The workup that we perform is often driven by the complexity of their CHD, but this can often be the presentation of heart failure or arrhythmias rather than acute coronary syndrome. So we have to be careful not to get down a rabbit hole of something that's not likely to be the case, and instead really try to make sure we don't miss the things that are more common, like heart failure and arrhythmias. But there are some ACHD patients who are at risk of coronary complications and coronary artery disease, and those include surgeries that have had prior coronary manipulation, coarctation of the aorta, Kawasaki disease. And now with COVID and MIS-C, I think a lot is yet to come about the impact that this is going to have on our patients and their coronary disease. Pregnancy is a big ACHD issue. Oftentimes, this is one of the most common things that bring our adult patients back to ACHD care when they've been lost to follow-up, is that now they're pregnant. And years ago, we used to think that our patients couldn't get pregnant and couldn't safely have children. And we told them, that really wasn't an option. But what we've actually seen is that the majority of our ACHD patients can safely get pregnant and deliver vaginally. Our research has shown that numbers of moms with maternal heart disease who are getting pregnant are increasing, and the mortality numbers are actually decreasing. So that's really encouraging. But it's necessary that these patients be appropriately evaluated beforehand, if possible. And that would be by an ACHD specialist and an MFM specialist. And then when patients are pregnant, it's important for them to have a fetal cardiology consult and echocardiogram, because we know that the incidence of CHD in children of both parents with maternal and paternal CHD is higher. We need to develop a multidisciplinary plan for appropriate labor and delivery strategies for these patients, and not just when to deliver, how to deliver, but where to deliver, and who's going to be involved in that, in their care and that delivery. Psychosocial issues are really common in our ACHD population. Anxiety and depression are more common compared to the general population. 31 to 33% of our patients have depression, and 26 to 28% of our patients have anxiety. Medical trauma is tremendously underappreciated. 20% of our patients meet criteria for PTSD. And again, we have to remember that trauma is a cumulative experience, and our patients have experienced that trauma in their pediatric lifetime. And now as adults, they're going to continue to have needs, and it's possible that they will require interventions, procedures, even surgeries. So we're going to actually trigger their medical trauma, and we have to be prepared on how to deal with that and support them and take care of them. And that's why it's essential that working with a social worker on our multidisciplinary team is necessary to properly care for our patients. So in conclusion, the ACHD population faces unique challenges in the delivery of care. We are gaining more and more experience, but the evidence base remains small, and there are still plenty of unknowns. Patient outcomes depend on access to appropriate care and continuity. These unknowns make it an exciting field. There are few specialists or specialties where there's this much we get to still figure out in our lifetime, and definitely lots of opportunities to shape the care of our patients and really make a difference in their lives. So thank you again for this opportunity to speak at such a great conference. And here's my contact information. I'm always happy to be a resource for anyone. So thank you.
Thank you, Susie.
Sorry, I thought I was speaking. I was on mute. So thank you, Susie, for a great talk. That was a lot of information to cover in a short amount of time. Our next speaker is Amy Kleinhaus. She is a nurse practitioner in the arrhythmia service line at Honor Health. She has nearly 20 years of cardiac electrophysiology nursing experience. After completing her doctor in nursing, Amy has served a large arrhythmia population in Phoenix and Scottsdale with a focus on cardiac device management and atrial fibrillation. She is certified by the International Board of Heart Rhythm Examiners as both an electrophysiology and cardiac device specialist, and holds a fellowship with the Heart Rhythm Society. She has a specific passion for mentorship and education for those new to the profession of nursing, as well as the growth of the role of APPs in specialty areas such as AFib and heart failure. We've given Amy the task of giving 2 talks here. The first of which is navigating medicine's new virtual reality, and the second is in contract negotiation. So Amy, you can just move from one talk to the next, and then we will follow with a Q&A session.
All right, perfect. Thank you. Can everybody, you guys can hear me okay?
Yes.
All right. I'm going to share. All right. Come on. There we go. All right. So yeah, so congratulate. Well, first of all, thank you so much for asking me to speak. It's always an honor anytime you get to, talk in a professional forum. And you guys get the pleasure of looking at me for the next hour. I apologize in advance, but 2 topics that I'm going to cover. The first one is talking a little bit about telemedicine and kind of our new reality in healthcare. And I've got, the promise of virtual medicine has been around for a while. This isn't all of a sudden very new. However, back in the beginning of 2020, COVID hit, and we pretty much shut down, and patients couldn't get access because we were not letting patients into clinics. We almost went into survival mode. as healthcare, and what we played around, an idea that we had played around with in rural areas and stuff like that, all of a sudden now everybody else had to get on board. And I think that we responded fairly well. I mean, with some of the tools that are out there today, I feel like overall we kind of stepped up and really made it work. However, there was still a lot of challenges, and there still continues to be a lot of challenges. And to be honest with you, with vaccine hesitancy and everything going on, our pandemic is going to become an endemic. Some people may even say it's already endemic. So with that said, virtual medicine and telemedicine isn't going away anytime soon. And at least in my practice, even though it's no longer the majority of my visits, it is a regular phenomenon, and I see patients virtually every week. So today I'm going to talk a little bit about some of the challenges, some of the benefits of telemedicine, as well as some of the best practice workflows, logistics, documentation, we all love to talk about, and then some risk management issues that we face with telemedicine. I'm working off two computers here because I got my notes down here. So I'm going to be, all right. So 2 sources for telemedicine that we work with. The first one is the audio only, which is going to be a phone call or a traditional landline. And the second one is the synchronous 2-way audio visual. And I think all of us can admit that having an audio component, having a visual component to the visit is much more beneficial. It has the capacity to do a visible medication reconciliation. We can review test results with patients using screen share techniques and capabilities. We can perform a limited physical exam. I mean, you can kind of get a little bit of a look at the patient. You can get jugular vein distension. You can check for edema. So you get a little bit of a physical exam on video. And then other things you don't necessarily think about, you can kind of get a good idea of the patient's living arrangements. Are they safe? What's their social support? So you kind of get a little bit of idea about that. So there's some benefits about having that visual component over just having a telephone call. The good news is that based on a Press Ganey survey that was published a couple of months ago by doctors.com, 83% of patients do expect to use virtual appointments even after the pandemic resolves. So virtual visits are going to be here for a while. And the data says patients accept it, that they receive care, they can receive care in the comfort of their home. They can avoid travel expenses. A lot of them, especially our elderly patients, are reliant on travel and reliant on others for travel, but that can kind of go away. It's less time for younger, more active people. It's less time away from work, from family, from other obligations. It improves healthcare accessibility, particularly in rural areas. It can facilitate quicker follow-up visits. You get access to specialists you might not otherwise be able to see without extensive travel, or you have to wait for prolonged waiting periods, and it improves patient compliance. Back to the Press Ganey interview, the survey was over 1,800 patients, and 93% have said would use telemedicine just to manage prescriptions. I mean, how many patients do we see who come into the office just so we can put eyes on them to renew their Lipitor for another year? So, those types of visits. And then 91% said that that telemedicine would help them stay compliant both in follow-up visits as well as with their medication regimens. And statistically, virtual visits have a lower no-show rate than in-office visits as well. Not to mention all of the benefits of social distancing in the middle of a pandemic. 3 main challenges that I'm gonna run through. There are a lot of challenges, but in my opinion, I kind of picked the 3 ones that I think are kind of the key arguments for people when we're talking about telehealth. One of them is the cost. One of them is access and patient unreadiness. And then the other one is just basic logistics. So talking a little bit about cost first. There is going to be an upfront cost to the technology. I think at this point, most of us have bit the bullet and just done it. We were kind of forced to last year, but those costs can vary greatly based on the size of your company or your organization. And then is it by patient? Was it already built into your EHR? Did you have to go and just have each provider spend $36 a month on docs. I mean, it's just sort of like plus the IT, plus the bandwidth, plus all that. So there is an upfront cost to technology. And the truth is, they've looked at this, multiple studies have looked at it, and they don't really seem to have any meaningful cost reduction to care. So the benefits of doing this really don't have anything to do with it being more cost effective or any sort of bottom line to a practice or a healthcare system. The patient benefit and the continuity of care is the primary motivation for telehealth, because there is no real, at least in the studies that I've looked at, there's no real benefit monetary wise. So health services considering implementing telehealth should be motivated by the benefits to the patient, not cost reduction. And most of the available evidence indicates that although telehealth provides an overwhelming improvement for patients and positive impact, continuity of care, as well as increased productivity of some services, most of the evidence suggests that it doesn't reduce the cost of care for the healthcare system. Unreadiness is also a big issue. Unreadiness and access. Broadband is a huge problem. So 19 to 42 million Americans lack access to fixed broadband services. That's a huge range, and it varies because the federal report that came out said 19 million Americans. Some of the private companies who are putting out reports went as high as 42 million Americans. So that's the range. The truth is probably somewhere in the middle. But disparities are really hard in the rural communities where 1 in 4 people don't have access to broadband services. The other thing that's an issue is the cost of broadband. Broadband can be quite expensive for patients, so that adds a disparity to people who are in a lower economic household. Alternatively, mobile data plans can be used. For those of you who aren't aware, I was surprised to learn that the United States is the 5th most expensive mobile data market by median gigabyte price among developed countries. So even this is going to be a cause for some patients in regards to disparity. It also has to be an internet capable device. And then you have to have sufficient technology literacy in order to even take advantage of broadband and the platforms like Doxy and Epic, as well as the smartphones that you have. There was a great study that came out recently that was testing unreadiness of patients. And what they found was in the elderly particularly, that 72% of patients who are over the age of 85 reported being unready for any sort of televisit, where 75 to 84 years old, 44%, 65 to 74, 25%. And then as they move down into the education level, the same thing, the higher the education, the higher the readiness. But those with a high school diploma were about 50% ready. Those lower than a high school diploma were about 74% ready. And then in the inequality in income, there was a disparity as well in low income households where 67% were not ready for any sort of telehealth. And the issue is, particularly back when COVID hit and we were shutting everything down and tele was the only way, at least in our clinic, we had tele-only visits for a couple of months when things were really going crazy. And these are people who just got lost. And so we have to try to re-gap that loss to follow-up and try to capture those patients and get them back somehow. There were a couple other really interesting stats. One was that non-English speaking people as well have less than 50 times lower telemedicine use. And then women statistically also have a lower use of telemedicine. And they think maybe that might be because of childcare, it might be because of differing work environments. But those are some other demographics that also don't have as good access to teleuse. So unreadiness and access is a second challenge. The third challenge is logistics. And one of the big issues, particularly in cardiovascular medicine, is that a lot of what we do needs objective data to support a subjective report. And particularly, I feel like it's that way in cardiovascular medicine because a lot of things present the same way subjectively. Shortness of breath and chest discomfort, palpitations. I mean, a palpitation is a palpitation. Everything presents as palpitation. So trying to find ways to get the subjective component or to get the objective component to match the subjective report the patient is giving you when you're working virtually can be very challenging. Sometimes you need a more advanced head to toe assessment. Sometimes you got to get an echo. Sometimes you got to get the EKG. Sometimes you got to get a device check. Sometimes there's reasons that those patients have to be seen. So trying to find ways to manage that when patients can't come in or aren't comfortable coming in, or maybe they're in Pine Top for the summer or something. There are some ambulatory monitoring options that are very good that can help us. Of course, the medical devices we have, the MCOTs, the Holters, the event monitors. There's also new technology using photoplasmamography, as well as wearable cardiac defibrillators. We do a lot of up titration of meds, based on these monitors. When you put someone on a 30-day MCOT and call them 2 weeks later and up titrate a med so you can monitor the response to the med. Wearable cardiac defibrillators, these devices here not only can give you a sleep position, they give you a 6-minute walk test, they can give you nocturnal heart rate variability, they can give you peak heart rates during the days. They can give you all of this data that helps you up titrate heart failure medications on patients. So trying to utilize some of this ambulatory outpatient monitoring equipment that we have to fill in those objective holes so that we can continue care virtually is going to be key. For commercial as well, you've got the commercial devices that you have the Cardia device that will send you a single lead ECG. You have the Apple Watch that can do it now. You have some commercial photoplasmamography as well that uses R2R variability to try to gauge whether or not patients are in AFib. All of those are tools that can be utilized. We use in our practice, we use those commercial ambulatory monitors all the time. Patients can email them. I can grab them from the email. I can actually put them in the note and use them to inform my plan of care as I'm building out my note as a subjective or as an objective piece of information to correlate with the subjective data the patient's giving me. The other one that's big for us in the cardiovascular space is remote monitoring of our implantable cardiac devices, our pacemakers, our defibrillators, stuff like that. Now, remote monitoring has been a class 1 indication for our defibrillators since about 2017. However, there's still a lot of reluctance in carrying it over because it is quite expensive to switch from being in office where you can have a rep come in and manage the devices and then trying to switch to that remote space where you have to manage that data. There are companies that will do it for you for the technical component, and then you just take the professional component. But getting patients on remote monitoring from a device standpoint, it should be a huge priority for any cardiovascular practice that's not doing this already. I mean, I'm not even talking about the mortality benefits, right? It's shown a 50% reduction in mortality for ICD patients, a 30% reduction in mortality for pacemaker patients, but also being able to identify new onset arrhythmias, with an average identification at 34 days for in-office visits to 4 days in remote clinic for new onset AFibs, which reduces, ED visits for stroke and AFib by 64%, decreases inappropriate shock, plus you have patient satisfaction, they're not having to come in. There's a slew of reasons that we should be doing this, which is why it's a class 1 indication. So that's one of the big things for virtual monitoring for cardiovascular patients. Centralizing, one of the helpful things for remote monitoring is a centralizing device monitoring software. In fact, some of the software out there now will actually do physiologic monitoring with commercial devices, such as Apple Watch. So you can monitor your patients who are running around with their Apple Watch via different centralizing device monitoring software. So there's all of these amazing programs and companies and platforms that can be used to help kind of fill the gaps of those virtual clinics. The nice thing as well is you can track patient compliance this way. And with today's monitoring, most of it is plug and play. So once we implant your patient with the device has the the device. Their patient has their device implanted. We get them on remote monitoring. They plug their monitor in and leave it alone. Very few devices do patients have to even participate in the downloads. Everything is done for them, but we're able to track patients through those monitoring as well. So at the end of 91 days, if I didn't get the patient's report I was expecting, I got people following up. That's how we've captured in our clinic a ton of our loss to follow-up patients from the whole COVID cancellations, is that we've been saying, hey, I can see this patient is on remote monitoring, but we haven't seen him in the clinic in 18 months. And you call, and it's because we had canceled all those appointments because of COVID. So this has been a great way for us to track compliance. This is an example of what it looks like for our clinic when we're tracking compliance and we're trying to see what's happening with our patients and as they're falling off and trying to go back in to capture those patients so that we don't lose them and we keep their care continuous. So those are kind of the three big challenges: the logistics of getting the objective data to support the subjective claims the patient's making, the access, and the cost. Documentation and billing. Everybody loves talking about documentation because we all love documenting so much. But there are some changes to how you document with virtual visits versus an in-office visit. The most important thing I would say is just documenting consent. Now, it's not required, Medicare does not require you to get informed consent to do a virtual visit. However, most states do require that. And a lot of commercial payers do require it. So the best thing to do is to just do it on everyone. And some EHRs have a template built in where you'll have a virtual template that you can use. We have a smart phrase because we use Epic. And so we just have a smart phrase that you just hit your .shared or .visit or .whatever, and then it's already there and you just have to put in, but it needs to include the fact that they consented that this is a telehealth visit, whether it's by phone or audio, where's the patient, where are you, and then who else is involved in the visit, if anybody else is involved in the visit, and then how it was performed. Was it performed on Doxy? Was it performed on Epic? Are you on FaceTime? How is that working? And so it's just the good standard of care because you don't know who's going to require it or who's not. So just do it. Okay. Now, before you prepare for a visit, you have to confirm the patient's physical and geographic location. This should be done at the time of scheduling. And I'm going to talk about this in a few slides because there's some risk management issues in regards to geography. But so you should definitely screen patients for geography at the time of the visit. Now, at the time of the actual, or at the time of scheduling, at the time of the actual visit, you should have your MA or whoever is doing the rooming of the patient, make sure that the patient's in a safe place where they can conduct the visit, where it's going to be quiet. They can't be in their car driving down the freeway. I mean, if they can pull over and have the visit, that's fine, but you got to be reasonable. So that's the first thing that they should look at doing. The other thing they want to do is they want to, again, confirm the consent. You know, you understand it's a telehealth visit, obviously, because you're phoning them. They need to complete a medical record and or the med reconciliation, the intake forms, troubleshoot any connectivity. So by the time that patient comes to you as a healthcare provider, it just is seamless right into your clinic and you can just pop in and start the visit with them. You complete the visit as you normally would. Because of the new rules with billing for the 99213s and 99215 visits, the physical exam isn't required anymore. It's all now medical decision making and time. So you just need to make sure that you document your medical decision making and the time you spent taking care of the patient and talking to the patient. Okay, so let's revisit geography. So the rules of geography licensure do unfortunately currently play a role in telemedicine. And there has not been any real clear legislation or guidance on how this complex situation is going to be resolved yet. Dr. Ross mentioned briefly about the Connect Act. The Connect Act was first introduced back in 2019 and kind of went nowhere. Now the Connect Act is looking at removing any geography restrictions from telemedicine. It's currently sitting in a committee. So it's hopefully going to push through this year, and that will remove kind of this issue and this consideration that we need to look at. But currently it hasn't been passed yet, it's still there. So our rules of geography are in place. And so we're going to talk about that quickly. But my go-to statement is always going to be, when in doubt, talk to your organization's risk management. They'll give you their recommendation for how to manage patients who are not geographically in the state you're licensed to practice. And it works a little bit different for people who live in another state versus people who live in your state but happen to be visiting out of state. And we'll talk about that here in just a second. But so this is a statement from Micah. Micah is for most people know who Micah is, but Micah is probably one of the biggest liability insurances for healthcare providers. And this is a statement taken from one of their articles. And when a patient's out of state, even temporarily, the answer is always the same. Physicians, advanced healthcare professionals, and other licensed healthcare professionals must comply with the federal and state laws, as well as the licensing requirements where the care is received. That is known as the originating site. Now, one of the things the CONNECT Act is looking to do is to change the definition of the originating site. And the site will be not where the care is received, but where the patient's home is. So that's one thing the CONNECT Act is looking to change. But currently it is defined as where the care is received. So where the patient physically is. Each state licensing agency oversees and disciplines the professionals it regulates. A physician providing care to a patient in Nebraska is subject to the rules and regulations of the Nebraska Medical Board. If a physician is not properly licensed in Nebraska, the physician may be practicing medicine in Nebraska without a license and subject to discipline. And then they went on further to talk a little bit about snowbirds. This is a little bit of a more gray area. And they said an Arizona licensed and located clinician treating an Arizona resident visiting Nebraska could also be subject to other Nebraska laws and court rules. Should the patient file a medical professional license lawsuit in Nebraska, the Arizona physician may be required to defend a lawsuit there. I love it when they have these statements and they have all these qualifying words like could, should, and may. So it's kind of a gray area. So again, if you're in doubt, ask your risk management kind of what their guidance might be. Medical licensure here, I'm not going to go through this whole screen with you because it's kind of in depth, but in essence, it kind of talks a little bit about the compact license that we use. So interstate medical license compacts that we have. And there's a little bit of a misunderstanding. We don't have a compact license to practice in every state. These states have a compact agreement that if I'm licensed in one state, I can get expedited licensure in another, but I still have to be licensed in that other state. So each state still licensed independently, but if I'm licensed in one state, I can have expedited licensure in the other. So it shouldn't take long to get it. They still have to be licensed in that other state. Now, when you're talking about incident 2 ruling and you are documenting under incident 2, you're bound by the licensure of your physician because you're technically documenting under the physician who's covering you. If you're documenting under your own license, then it's your own license that has to be in the right state of practice where you're at. And then, and I think that's actually what my next slide says. Yeah, so the compact doesn't issue a single interstate medical license. Not like, oh, look, I'm licensed in Arizona, but I am a compact state license. I can license and I can practice in Alabama and Dakota, North Dakota and South Dakota and Tennessee. It doesn't work that way. You actually have to still contact their boards and get licensure there. And then for APPs as well, it even gets a little bit more confusing in that our scopes of practice are way different, right? So you have a full scope of practice here in Arizona, but in North Dakota, you don't have a full scope of practice. So how you practice, if you're documenting and billing under your own license, how you practice is going to be completely different between the different states you hold licensure in. Again, hopefully by the end of this congressional cycle, this CONNECT Act will pass, because it will take away all of these geographical restrictions that are currently in place. So as Dr. Ross was talking about, if you want to get involved, this would be a great one to contact your legislator on and talk about some of the challenges of telemedicine, particularly for Arizona, where we see a good portion of our population out of state for a good portion of the year. So that's my spiel about geography. Lastly, but not least, I just wanted to talk about the audio codes for telephone encounters. So 99441, 99443. These ones are documented by time. So you have to designate time that you spend on a telephone with the patient. However, with the COVID expansion that has been extended, the many insurances are recognizing regular office visit codes, even for audio only. So what I do in my practice is I bill it as a visit. Even if it's a telephone encounter and I write my note and I put on there in my consent, spoke by telephone, under the bottom, I will bill it as a 99213 to 99215, not a 9, but 99213 to 99214 visit, because I'm not going to do a 99215 on the telephone, but 99213 to 99214 visit. Then I'll actually, when I go to bill it, I'll just click on it, coder review. And then the coder can compare it to the insurance. And if they need to down code it, they can down code it. But I'm right currently with the expanded rules. I'm just, everything that is a telephone visit that was booked in my schedule, I bill it as a 99213, 99214. And then ask for coder review. If it's a telephone encounter, like the patient is away or in Flagstaff, and I call the patient to go over a medication and we speak for 30 minutes, I'm going to document time and I'm going to submit a bill for 99441 visit and for my time for that 30-minute phone call that I had, which is also nice about the telemedicine expansion, is you can use those codes for these prolonged telephone calls you might have with patients outside. And that is it. Any questions?
I think we reserve the questions and answers at the end of the afternoon session, so we can go ahead and proceed with the next topic, which is contract negotiation.
I can do that. Oh. All right, hold on, let me grab it in my other one. Okay. Okay. All right, well then again, I'm back. So when I got asked to speak about contract negotiations, I know this is something that we all struggle with a little bit. And so I kind of it's kind of arcing and a little bit broad. It is going to be we'll just get into it. We'll go through it. I'm sure there'll be questions. Okay. So there's so much conflicting information online when you go in. Like when you go in and you sit down and you're like, okay, how to negotiate a contract, and I'll give you all the do's and don'ts. What this guy says to do, that guy says to not do. And so then you're kind of stuck, like, well, what am I actually going to do? I'm going to turn a pointer on here because I've got some. Okay, I'm going to turn my pointer on there so I can use that in a second. Okay, what this guy says to do, that guy says don't do. Do you discuss your current salary? Don't discuss your current salary. Should I give a salary range? No, don't give a salary range. Should I make the first offer? It's kind of this, you don't really know what to do as you're going in. But I think there are some very clear do's and don'ts that you definitely should do, and a couple things you definitely should not do. And then everything else, you almost have to kind of feel it out as you're with the person that you're with. So but yeah, so the idea is who has the best course, who knows what to do. And the truth is, who knows? But I do know one thing, and this might be a little bit specific for nurse practitioners, particularly new grad nurse practitioners. So most of us come out of NP school and we've been nurses for years. I mean, I was a nurse for 13 years before I finished NP school. Now, your entire profession as a nurse, you're told how expensive you are and how much you cost to the healthcare system and all that stuff. There has to be a shift in mindset when you move from being a nurse to being a nurse practitioner. And that's because you're no longer overhead. You are now a revenue producing participant of the healthcare system. So you have to break from that mindset in your head that you're overhead, because you at this point now will be making money for them, not taking money from them. So that kind of, yeah.
Amy, sorry to interrupt. I think you still have your old slideshow that you're sharing from the last talk.
You can't see my new slideshow?
No, it just says questions.
Oh, thank you so much for saying
You're
that,
welcome.
'cause I would have just kept going. Give me 2 seconds. I'm going to stop sharing and then start resharing. Let me this one. Can you see this now? Contract negotiations.
Yes.
All right. Haha. That's good because it's a pretty slideshow. You got to see it. Oh, can you see that?
Yes.
It says you are no longer overhead.
Yes.
Yes.
All right. All right. You are no longer overhead. Congratulations. All right. Okay. So I want to talk a little bit about the role of the advanced practice provider in the cardiac team. And ACC has been very welcoming to APPs. And back in 2015, they kind of officially made a policy statement about our role. And with the ACC, we've been recognized since 2003. They've been pushing forward, and it is nurse practitioners, it is PAs, it is clinical nurse specialists, it is PharmDs. All of these people kind of make up this group of advanced practice providers. And we've been offered fellowship through ACC. We now have representation on the board of trustees with ACC, and so there is a lot of, at least with the American College of Cardiology, a lot of recognition that our participation in the team is critical, particularly as physician shortages continue to drop. Now, the specific role of the advanced practice provider is really going to be dependent largely on your postgraduate training. There's a lot of diversity in your background as well, and that should be seen as an asset, what you bring in with you when you come in. And what I mean by postgraduate training, so you look largely about, like, broadly speaking, nurse practitioners, their strengths will fall in chronic disease management, patient education, transition of care programs. CNSs, their strengths are going to fall in developing and improving specific cardiovascular programs. The physician associates, thank you, Heather Ross. The physician associates are their training leads them to more technical clinical tasks of the physicians. And then the PharmDs, of course, their strengths are going to be in the med reconciliation, particularly in the transition of care, med adherence, complex drug regimens, and providing preventative care in certain circumstances. So different roles lead to different things. This is kind of a summary of the education requirements of the different advanced practice providers across the board, which I'm not going to dwell too much on because this will get too long. And then the next question I want to touch on really quick is leadership in the cardiovascular care of patients. Unfortunately, a lot of this is a more political question than a clinical question. I think for the most part, us in the front lines, we generally have a good idea about who the logical leader of a team is. The leader of the clinical team should be the lead clinician. Generally speaking, that's going to be the cardiologist or the CT surgeon or the electrophysiologist. In some situations, in specialty clinics, like in certain heart failure clinics or something like that, you'll have a clinical lead who's a nurse practitioner or a PA, and then they'll have like a medical director that they'll respond to. The managerial leadership, this is the non-clinical supervision over NPs and PAs. This will vary kind of dependent on where you're practicing. In an academic practice, the managerial leadership is determined kind of by a hierarchical academic structure. In private practice, it's usually determined by ownership or bylaws. Who owns the practice? That's going to be who the managerial leadership is. And then administrative and for clinical program development, it's going to be the medical director. He would be the logical leader for the clinical matters, but then there will be administrative partners for day-to-day stuff. I feel as advanced practice providers, one of my pet peeves, I'm going to have to say, is when you're in a practice and the person who is clinically supervises and managers the APPs is a non-clinical person. So I think it's important as you build structures and you're negotiating what your role is in a new organization, you get an idea of the org chart, and on the org chart where you are in that org chart, so you know who you report to and then who is responsible. Because if you feel like you should report to a physician or another nurse practitioner or another PA, another APP essentially, and the day-to-day managerial stuff, like you want to report your PTO or you want to do something like that, then you would have an administrator do that sort of thing. But you want to make sure from a clinical standpoint that your reporting structure is to someone clinical, and that's usually the most appropriate way. But so this came directly from the 2015 ACC policy statement. It says, rather than promoting fixed and inflexible rules regarding team leadership, we should recognize that the members of the cardiovascular team are professionals and as such are self-regulated. The sense of self-regulation will engender an attitude that the team leadership role goes to the team member who's most qualified to lead the team to perform the task at hand in a patient-centered and responsible fashion. So that kind of summarizes that really well when we're talking about who are you reporting to. And then here, I'm a huge proponent of having advanced practice providers in leadership positions. This is a really good summary. You can find this in the ACC statement about some of the different settings and programs that have been researched and then that are led by APPs and how their successes are. So you see here, you've got chronic heart failure management. And so this would be a heart failure clinic. This is disease state management. And they've shown reduced hospitalizations, reliable use of evidence-based therapy and dose titrations, and consistent documentation of education, all the way down to anti-coag clinics, disease state management. Our PharmDs run our anticoagulation clinic. I think they do an amazing job. Improve safety, patient safety through reliable education, all this stuff. So you can see all these different areas where the APP roles are expanding and moving more into leadership, which is really nice. So let's get to the nitty-gritty of kind of some of the do's and don'ts. I think the very first thing you have to do when you're getting ready, so you've applied for a job, you've gotten the interview, things are coming out to you starting to have to talk about numbers. And the question is, what do you do? What don't you do? One of the first things they always ask people is you have to familiarize yourself with industry salary trends. What is your market value in your market? Your market value in Phoenix, Arizona is not going to be the same as your market value in San Francisco, California, which is not going to be the same market value as Baton Rouge, Louisiana. I mean, your market value is going to be different depending on where you are. There's two websites that are pretty good. One of them is payscale.com. One of them is glassdoor.com. These are free websites you can pop on, input your data. Payscale is a little bit more in depth. It asks for leadership history and stuff like that. And it will give you the range that you should expect to be offered in this area. And that's based on actual data that they've collected from your colleagues in the area. Then and the other thing I would say is speak to your colleagues and ask your colleagues, hey, listen, what should be my range I'm negotiating at here? What are your thoughts? Here's my background, here's my experience. And they'll give you an idea of kind of where you should be. So don't be afraid to speak to colleagues. Nobody benefits from us not sharing that data with each other, but the people who are negotiating contracts with us. Like, we don't benefit if we don't share it, if we keep it to ourselves. So I'm not saying advertise it. I'm not saying, go on an ACC conference and say, I made X amount of money. But on a small personal level between colleagues, there's nothing wrong with doing that. And then when you go to negotiate, then you can use verbiage like, hey, similarly situated employees will be making this much, or hey, based on my research, my experience, my background, I should be making this much. So that's kind of what you should be looking at doing. If I pop down here, do your own research and know very much that federal law prohibits employers from forbidding you for speaking about your salary or with your colleagues. So if anybody ever tells you you can't, that's wrong. The National Labor Relations Act states that employers can't ban the discussion of salaries and working conditions among employees. So you absolutely have a right to discuss this with your colleagues. And I think nowadays, nobody would actually try to forbid you from doing that, except maybe small private practices here or there. But they can't do that. So let me come back up to here real quick. Actually, let's stay here. What I did essentially when I was kind of looking at doing this was I wanted to give an idea of, okay, well, knowing your numbers are important. What are the numbers for Phoenix, Arizona? So I went to payscale.com and I made a dummy little account and I put in information about myself and pretty much said, how much should I be making? And Payscale, based on 116 other reported people similar to me in my area, it gives me a big range, 102 to 150,000 a year base salary. Glassdoor is a little bit bigger. Not joking, it was 94 to 158,000. But that was based on 38 reported salaries. So they're using it based on what other NPs are reporting they're making. So what I did essentially is I collected data. I made a survey and I disseminated it anonymously among a group of NPs that I know. And I said, if you're comfortable, fill this out, send it to me, everything stays anonymous. And 42 of them did. So I'm going to review some of those results today. Now, interestingly enough, the Payscale and Glassdoor ranges are just about accurate. I mean, so here's our base results for our small survey here. So we had a total of 42 people respond. So our N is 42, which you can see down here. And then approximately 80% of respondents reported making between 100 and 150,000 a year. So falling inside that same window. I didn't say tight because I think it's a big window that Payscale and Glassdoor gave us. And you can see here, the percentage really fall here between 110 and 140,000 a year. So right between here is kind of where the median, I believe, was 126 of this group here. And then it kind of break it down here. The green stands for NPs and the blue stands for PAs. So NPs and PAs are relatively comparable in regards to salary. Productivity bonus. The majority of people in our valley do not make productivity bonuses, but they do make performance bonuses. So I should say about half. So 46% of patients made performance bonuses, and then this is the general range of the performance bonuses that were offered to the NPs that responded. Productivity was more rare, and these were either RVU based, some of them were accounts received based. I think those were the two main ones. And so only about 14% of people receive a productivity bonus on top of a performance bonus. And most of the positions, I think 94% of the positions are benefited. This here is based on practice setting. So outpatient, if you're primarily outpatient, blue was your dedicated inpatient, and orange is you had a mix of both. So I really felt like that didn't really have much of an impact at all. So pretty much pay is pay, whether you're inpatient, outpatient. I know that some places like Mayo does differentiate and they tier them different. So like an NP who works outpatient is a different tier than an NP who works inpatient, and they have a different range. They kind of overlap a little, but their ranges will be a little bit different. So I know they structure theirs a little bit different. And then DNP is blue and masters is, or the doctor is blue and masters is green here. Didn't really feel it was too telling there either. How many hours a week you work? So dark blue is 21 to 30 hours. which makes sense because that falls in the lower echelon. The salary range is over here on the side. So you have less than 80, 80 to 90, 90 to 100, 100 to 110. So you can see here, lower hours, obviously less pay. And then you can see here 31 to 40 hours. And then the lighter blue here is actually 41 to 50 hours, which was the majority of people. The majority of people reported working about 41 to 50 hours a week. And then these are the people who are working over 50 hours a week. If you're working over 50 hours a week, you should not find yourself in this pay scale down here, just saying. And then nurse practitioner type, the green is an FNP, the blue is acute care, and the yellow is adult gero. This one here was years in practice. So this one I'll talk about a little bit. And I'm going to kind of omit the person up here because this person, it works under 40 hours a week. So there's, or she works under 30 hours a week. I'm assuming it's a she. We didn't actually get mostly genders. 1 to 2 years here, you can kind of see here. And then you see 3 to 5, you kind of see here. And then 6 to 10 are here. And then 11 to 20 are here, and greater than 20 are here. I think if we had more data points, these lines would kind of get a little bit more profound, but you can see a little bit of difference in obviously patients, APPs who have 1 to 2 years experience versus APPs who have 20 years experience. There is a difference in pay there. And then your primary employer. This is another one I found really interesting. And I think for that is you're going to have a little bit more wiggle room when you're negotiating with a private practice versus a system, a hospital system, because hospital systems will have compensation committees. They will be running market analysis probably every 5 to 7 years. They should be running a market value analysis to make sure that they're paying consistent with market value. So they have a little bit of a tighter range, and that's the dark blue, which is the healthcare systems, versus private practice, which are green and can kind of, I think, you have a little bit more negotiating power with those ones. So that was kind of the overall summary of what we got from the people who are local. Again, I really feel it was consistent with what we found on pay scale and on Glassdoor. But ultimately, you're the one who has to step up, right? I mean, there were people who had 1 to 2 years experience who were making, 30,000 more than some others. So I think it's going to be really important that you as an individual are bringing in your experiences with you. So I wanted to talk a little bit about the do's and don'ts as you're kind of now sitting at the table with people. And the first one I would have to say is don't fail to build your case, right? Know your data, know where you should be in a range, and don't fail to build your case. Use your professional, personal life experiences, because you bring both of those to the table. If you are a nurse practitioner and it's particularly a new grad, do not let them devalue your nursing experience. If you are a critical care nurse, if you had critical care certifications, that's value that you bring to this role, and that needs to kind of be viewed as well. If you are a physician associate and you were a paramedic or an EMT, or you served in the military as a medic or something prior to becoming a physician associate, that experience comes with you. And so you need to make sure that they know that, hey, I'm bringing this value. If it's a research driven clinic or hospital and you have experience as a research coordinator, or have served as a sub-I in an investigator, or if you've ever presented an abstract or something like that, you bring that with you and you present that to them and let them see all the nooks and crannies of your experience so that you have something to put forward to them. I work a lot with hiring, and recently we were hiring an individual, and our company offered them X amount, and I felt there was a higher value because of 3 things on the resume that I turned around and pushed back on, and got a higher offer for that person because I pushed back on just 3 things on her resume. And so it's important that you really kind of make sure that you bring those to the forefront to say, hey, listen, I have X, Y, and Z, your certifications, your nursing experience. Don't stretch the truth, right? Don't say you have personally cared for one. Okay, there was a scene in the movie Office once where Daryl said he had moved 1 billion pieces of product because they delivered paper. So he was talking about pieces of paper. Don't stretch it. You don't have to stretch it. Just be authentic and be genuine. And so people know what your value is that you're bringing to the table. Let's see, do not commit to starting at a low salary. I gotta find myself here. As a new grad, I once heard a hiring manager tell a new grad PA that in her opinion, new grad PAs and NPs were useless for the first 2 years. So they would lowball them on salary. That's ridiculous. Their expectation of you is going to be the same as every other NP and every other PA in that office. And within the first year, you'll be making money for them. So that is not, don't do that. Don't let them tell you that. That's not true. They may say, listen, for the first year, we're going to give you this, but we'll renegotiate after 1 year. If you're going to do that, you need to make that very, very, very clear. There needs to be renegotiation with an expected, you can even try to say, okay, but I'm going to want at least a 30% uptick, or I want it, but it has to happen on day X, and any raise that comes after has to be retroactive to this day. Like, you have to make it exceedingly clear, and you need to get it in writing. But if you absolutely can avoid starting low because you're a new grad, your value is there. I mean, you can kind of see in the past survey that we did here, we had new grads starting $30,000 higher a year than other people. So that new grad, you have to then build up your past experience saying, yeah, I know I'm a new grad, but I worked in the cath lab for 5 years, and you're looking for a cardiac NP. Like, I can run circles, like I can do this, and just kind of be willing to play that card. We all have different employment DNA. And so what you need to feel satisfied in one job is going to be completely different than what another person needs to feel satisfied. So if you are finding yourself on the lower end of the pay scale, don't automatically assume I'm going to go and negotiate a higher salary, because if your job suits you and you're happy in your job, then, negotiate appropriately. If you want to go back and say, listen, I feel based on my research and based on people who are similarly situated, I would like my compensation adjusted for the market value. Could you do a market value adjustment? I would do that over saying I want to raise. Say, hey, could you revisit my market value, because I feel based on my research, my market value needs to be adjusted, and have them go about that way. But also remember, there are a lot of non-salary perks that can be negotiated. This is a little bit more pertinent for private practices and a little bit harder to do in a hospital system where they have a tendency to kind of have everything already like predetermined. You get this much vacation based on this many hours, and that's all kind of been written out and predetermined. It's hard to push back off for those types of organizations. But for private practice, you have a little bit more wiggle room. And you can ask for things like more PTO. You can ask for things like higher level of CME. You can ask for call bonus if they don't offer call bonus, or a bonus day or call day off. So a lot of places will give you a day off the week following your call weekend to help with work-life balance, license coverage, travel stipends, stuff like that. You also want to make sure you establish who you report to. That's going to be very important down the line, because you want to make sure that the person you're reporting to is a person who understands what value you bring. And I think as hearing an office manager tell an APP you're going to be useless for 2 years tells me that office manager doesn't recognize the value an APP brings to the office. So you want to make sure that the person you're reporting to recognizes your value. The other thing you might want to negotiate and talk about are the expected lengths of your office visit. In a private practice, where everything is a little bit tighter on the bottom line, you're going to have a lot more pressure to shorten time visits so you can see more patients and turn more revenue. And so you want to make sure that you recognize that practices that a 15-minute time slot for you to do a chart review, visit the patient, and write a note is almost impossible to happen, which means now you're going to be writing notes in the evening until 7 or 8 at night. And those are hours that you're working and hours you're away from your family. So maybe you accept a little bit less salary, but you negotiate the fact you only want 30-minute time slots. So, I mean, it's kind of like a give and take. Sometimes it's about the terms, not necessarily about the bottom line. Do they offer things like student loan relief? Do they offer things like financial planning services? A lot of these private practice will have these bundles for their physicians, and you'll be able to kind of co-op some of those bundles and say, hey, if your office does financial planning for your physicians? Will they do financial planning for your APPs? And that can take a little bit of that off of you as well. So there's all these other little perks you can kind of talk about and ask about to kind of fill in the gaps. So above all, don't wing it. I would use the word compensation and not the word money. If they ask for a range, you can ask for a range. Say, well, what do you have budgeted for the position if they're willing to give that to you? If you give them a range, just know your first offer is going to be likely at the low end of that range. And then you always want to inquire about work-life balance if that's important to you by asking about their practice culture. If you say work-life balance, they'll say, oh, yes, of course we promote work-life balance. But asking about practice culture is important. You're going to find a little bit about that when you're having a conversation with them, like when they say, I'd like to negotiate 30-minute time slots or 20-minute time slots for offices. If they say, no, we do them in 10 or 15 minutes, that right there is going to tell you what their expectation for your work-life balance is going to be, because you're going to be writing notes until 8 or 9 at night trying to finish up your documentation. And then the other thing I would say is don't focus on need. Like I need, I want. Keep it focused on the value you bring. This is what I bring. This is what I do. That's going to be important. And that's going to kind of drive home. And the other thing is keep in mind that you don't want to put all your eggs in one basket. So if you're applying for jobs, you apply to multiple jobs so that hopefully you have multiple offers to be considering, and you can use that to kind of wiggle room a way around as well. And say, listen, I have another offer, but this offer is also saying, you know, they've got student loan coverage. You guys don't. What can we do about that? So, I mean, you can kind of, you don't want to throw it in their face, but you want to kind of understand that you need to be competitive. And so not going, if you're going to move and you've got a job offer, you've got your job and you've got that other job, and those are your 2 jobs. But if you're looking for another job, apply to 2 or 3 jobs. It doesn't hurt you to apply and have interviews. If anything, you get really good practice. And that's it. Questions?
Thank you so much, Amy, for the very in-depth research and discussion you did with these 2 topics. I mean, very, very interesting and fascinating, talk that you gave us. And, when I first asked the survey about, from the cardiovascular team, like the top topics that they picked is basically contract negotiation and the coding and billing, as well as the telehealth medicine. So again, fantastic talk.
Thanks.
Amy, that was just awesome. A question for you, with your research and the survey data that you put in there, was it specific to cardiovascular practitioners or was it all comers?
Are you talking about the salary data?
Yeah.
So the salary data from PayScale and from Glassdoor were cardiology NPs, and then I did cardiology PAs, and they pretty much overlapped the same range. There was a little bit of variations on the end, but they pretty much overlapped the same range. The specific data, those are just cardiovascular nurse practitioners here in the Phoenix market.
Fantastic. Yeah, I was trying to make sure that was true.
Yeah.
So I have a question too about the survey that you did. Mm-hmm. Are any of the APPs have any of them have profit sharing with the group that they work for?
None of them did. Yeah, their product there were 3 bonuses styles. One of them is performance bonus. One of them was weekend bonus, and then the weekend call, which I don't think is bonus. I think it's compensation. And the other one was the productivity bonus. And so performance bonus, was, I didn't go into detail on how performance bonus was divvied out. I just assumed that, most places do it the same. You'll have an objective metric. You'll also have a subjective metric, like your physician gave you a tick mark and you showed up and you did all this. The productivity is a little bit different. Some places the productivity bonus was RVU based. In some places the productivity was billed encounters, and some places the productivity bonus is accounts received. And I know that there are some practices that are really, really good about reporting to their NPs about their revenue. And I know the last practice I worked for, I was given a quarterly report about my revenue. So it was really nice. It was a monthly report about my revenue. So it was really nice as we were working towards productivity. The position I have now, I don't have productivity bonus, but I do get, but my encounters that I bill do play into my performance bonus. So I do get a report on that. I know there have been a couple NPs in the Valley who have gone to their offices to ask their revenue to kind of see what their value is. Which is something that your practice should be able to give you. They do it to the physicians all the time. They should be able to give you those numbers as well. And I think that's important to know, particularly if you are looking at going back to them, if you feel, you look at the range that we talked about today and you think to yourself, man, I've been in NP for 6 years, 7 years. I feel like I'm a little underpaid for what I'm doing. One of the very first things you can do is arm yourself with the facts and ask your office manager or your billing department to give you a report of your billables for the last 12 or 24 months. And then you can go into them. Just remember, your billables don't just cover shouldn't just cover your salary though. There's always going to be some overhead associated with your existence, right? An MA has to room patients for you. There's room space utilized. There's all these little costs we don't think about. So generally speaking, when you're talking about a productivity bonus, your bonuses start to come out after a certain amount is collected above and beyond your base salary. So for example, if your base salary is like $120,000 a year, your productivity bonus should start probably 2 times above that. So once your billables hit 240 and beyond, then you should be able to collect a portion of that back as productivity if that's how they want to lay out your productivity bonus. So there's always going to be some stretch because there is technically overhead associated with you just having to run clinics, right? The lights have to stay on, the MA has to be paid, the EKG paper has to be bought, all of that stuff. So there is an overhead associated. So your collectibles shouldn't just pay for yourself. They should also cover your portion of the office overhead to practice in that office. So that's kind of generally the rule of thumb is and that's negotiable with them if they're going to do a productivity based bonus structure. They'll generally tell you what your target is before you start collecting productivity. And then usually that productivity is going to be a percentage back of any further collections above and beyond that productivity number. And that's one way that productivity bonuses can be given out.
In your research, did you get a sense of how many NPs had all of their notes, for example, signed by physicians? That's true when our NPs in our system are within the inpatient service, for example, versus true independent practice. Were you able to see any of, or did you get an idea of how many percentage of people?
No, I didn't even ask that question on the survey, how many are incident to dedicated and how many open their own clinics or run their own clinics.
Yeah, because that will clearly affect your accounts payable, like if that bill is attributed to the physician and not you, then it's not gonna pop up. And that clearly should be taken into account in some way. And I've noticed that there have been many different models of exactly how, if you are going to use RVUs, the RVU attribution is then balanced off between the physician for incident 2 and yourself. Or does it just float off and you just get a flat salary, and that's probably what some of those models are based on.
Yeah, I think it's super interesting too to understand that a lot of places don't assign RVUs for co-signing an NP's note.
Yeah, that's correct.
So the NP collects the RVU, or the NP or PA collects the RVU for the visit. The physician doesn't collect RVUs for signing the note.
Oh, I see. Okay, yeah. I think
if it's RVU based.
Yeah. Because and then that's the important thing for a lot of people to understand. RVU assignment to a person is not dictated by accounts collectible. It's dictated by the system that you work for and how they decide to attribute an RVU to a person.
Mm-hmm. Yeah, I know it. At least at Honor Health, the RVU is the physician doesn't get the RVU for signing off for co-signing a note. They co-sign the note because the hospital system then can get 100% reimbursement for that code as opposed to 85% reimbursement. And we do both. Like if I have an independent clinic twice a week where I bill under my own license, and I have a mirrored clinic with one of the EP physicians that I will bill incident to. And then of course, you can't bill incident to for Medicare or Medicaid anyway, access patients, you can't bill incident to. And then new problems. So if we have an existing patient who had, let's say, has a history of SVT and his SVT ablation now comes in with AFib, that's a new problem. I have to bill that under my own license because it's a new problem.
Yeah, did you get any line of sight of how RVUs might be attributed for PAs? Because PAs are not independent, physician, associates right now.
Yes, physician associates. I like that.
I like that. It's better. It's better.
I like it.
They never bill under their license. They're billing under the physician's license. So how does that work with regards to RVUs or whatever it is? They will never see accounts billable data, right, for a PA?
So I think, I believe that they can. I mean, but that's going to be something that is going to be specific to each company. Like the previous office that I worked for was a private practice, and they would give the PAs their collectibles.
They were able to do that.
But they didn't do RVUs. Their bonus structure, their productivity bonus structure was based on on accounts received. So on collected received accounts that went towards that PA. So I think that there's obviously a way to do it. It's just a matter of whether or not your corporation or the organization is doing it for you.
Last question from me. I didn't want to hog all the questions, but physicians often have lawyers look at the contracts. What is your advice for advanced practice providers?
I mean, I have never had a lawyer look at one of my contracts that I received, but I also have, they've also been really straightforward. I've never signed a non-compete agreement. I wouldn't sign a non-compete agreement. So if you get a contract and you're looking at this contract and you're thinking to yourself, this seems a little bit questionable, there's some things on here I don't like, then you should have someone look at it and kind of give you feedback. Phoenix is a small town. I had a friend who signed a contract with someone and had a 5-mile non-compete agreement. But the problem was that they had 2 offices within 5 miles of the 2 major hospitals close to her. And so when she wanted to leave the practice, she was stuck not knowing where to go because all the hospitals were right in the area where she had signed the agreement. And it was like a 5-year non-compete. It was ridiculous.
That's ridiculous. That's non-enforceable. That's actual, 5 years. That's ridiculous. And that brings up a great point. How many % of APP contracts actually contain non-compete provisions? I've never heard any data on that before.
No, me either. I think that if you're going to find that, you're going to find that mostly in the private practice arena.
Yeah.
Great. People trying to slip it in there.
Yeah, but just, thank you. That was just superb. And I have not heard such a great talk on APP contract negotiations thus far, whether here or on the national level.
Are there any other questions for Susie or Amy from the attendees?
Should we check the Q&A box?
I just did. There are none.
Okay, good.
So guess we're going to be ending the session earlier. Okay. I'd like to thank the excellent speakers who actually spend their time sharing their expertise, educating our cardiovascular team, and also the attendees for participating and spending their Saturday learning from our experts so they can provide and continue providing excellent care to the cardiovascular community. And lastly, we'd like to thank Jensen for supporting our ACC CVT Symposium.
Yeah, thank you so much, Cecilia and Barb, for putting together such an excellent program. The good news nowadays is that these things are not limited to now. They will be available as a video on our website, and people can come back and watch this. Obviously, I don't think you can get CME credit if you watch it later as a video. So sorry for that. Thank you, Ron. I see you over there. That was a great talk. Really enjoyed that. Very thorough, very comprehensive, fantastic. And then everybody else, no one else is on live. So with that, I wanted to wrap. I suppose I'll help wrap up. We have another the poster competition or abstract competition in December 10th, I think, Saturday. This is Saturday, whatever Saturday that's close.
December 11th.
December 11th. See, Liana keeps me. Don't show up on the 10th. Nobody will be there. Maybe you automatically win if you show up on the 10th. Yeah, December 11th, Saturday. We'll have residents and fellows and specific APP section, and there'll be a short best case thing for the people who have graduated, and we wanted to give opportunity to attendings as well to have some fun. Yeah, so I hope we'll see you next year in person.
In person.
Yeah, thank you so much.